Okay. It's connecting.
How do I remove this echo? Что тут это считаю? Считаю. Español нет. Todavía más hablar español.
Okay, I'm going to take you off the screen share.
But the speaker will be seen.
Okay, I want you to go to Neurosurgical TV on your smartphone to see what you see. Okay, do you see it on your Neurosurgical TV?
Just a moment.
Yeah, let me change something here. Hold on.
Încerc să iei Joe, Bine, ok.
Tu pôr o estúdio das pessoas de amor, ele não consegue pisteira. E eu não consigo pisteira.
Okay, so I see myself.
Oh, good. So you see it. Let me put you on the front page here. Hold on.
There is a 1 minute lag.
Okay. Okay, you should be on the first page now. Okay, you should be on the first page. Do you see it?
On YouTube? Yeah.
No, on Neurosurgical TV.
Yeah.
Yeah, there you are, right there. You see yourself, right?
Sorry. Didn't quite catch it. Function.
We added all this up. Okay, okay. I have to go promote. Okay. Or anything else you want to test?
No, just I was thinking that in the YouTube video feed you see the speaker.
Yeah, let me give you the YouTube link because I put it on YouTube already.
Okay.
Hold on. I'm going to send it in the chat in the WhatsApp. See it right there?
Yeah.
Now it's a little slower. It's slower than the live. There's a delay of like 15 seconds in the YouTube. Like television, they have delays for censoring and stuff. So I don't know why YouTube does it, but they do it. So now you got to be careful.
Uh-huh.
You can't keep your YouTube open while you're doing a presentation because it'll have conflict with the audio.
Yeah.
So just get it. The best way to simplify it for you and the speakers is to get off all programs other than Zoom. Like in other words, don't have a window open with the YouTube, then it's going to cause problems. And they'll get sound from the background.
Yeah, but we don't need to have the YouTube open because we have the Zoom already. So
Yeah, you just need Zoom anyways. You don't need anything else. Okay, I got to do some last minute promoting. Do you have the final schedule? Because I never got it from you last night. I got a kind of a tentative schedule.
I think it's the final one, but let me check. We have it printed somewhere.
Okay, just send it to me if you got it.
I send you. Okay.
Алло. Алло.
So I send you a photo.
Okay.
In WhatsApp.
Okay.
But I think it's the same text I sent you yesterday.
Oh, okay.
We have a different schedule for the morning because we have the representative of the Spanish embassy and the representative of Ministry of Health.
Okay.
They will held a little talk, so we might not begin at 9, but. And I will mute the feed from you during the presentations.
Yeah, everyone should stay muted during the presentation.
Ti do më siti numra? Po pse nuk shkon te Albana këtu?
Okay, you see.
Ti goca nga kam I goca.
Oh, okay, no, I don't know if I have that schedule. No, I don't have that one. Okay, that's good, thanks. That's for until 3 o'clock, right?
9 till yeah, probably till 3.
Yeah. Okay.
I suspect it will be less than 3, but
okay. Well, as long as you need.
Alban, shifi që këta numra ID e që bëhet?
Çfarë ID?
Të kësaj motrës tonë këtu. E ke një ashtu më duket?
Jo, është neurosurgery.
E kam shtu.
Po është.
E kam shtu dje. Dje par dje më men. I shtova që vetëm kena hallin e numrit. Jo, është. E mirë.
Po, është më të përmë të përë.
Okay, so Mr. Bennett,
Yes.
may I walk around?
Yeah, sure. I'm all set. I'm all set. I'm all set. I'm ready to go.
Okay, so I leave the link open.
Okay.
And I just mute you.
Yeah, that's fine.
Okay.
Fine.
And we communicate via WhatsApp if we have anything.
Yeah. That's a good way to do it.
Okay, great. Thank you.
Okay, you're welcome.
Të lutem më thuaj një kari tjetër, më thuaj edhe 6 karike. Të lutem. Unë jam në sallë jam. Më duhet një 6 karike dhe nati duhet të më marri 100 relasa në depo. 100 relasa në depo. Në rregull dhe 6 karike. Po, hajde vetë. E po se i një vonë, se ka të shtiku një të shfarë.
Oh. Ska gjë jam. Unë arsi ka bëjon që dëgjojmë zhurmën e këtyre. Ai një dela të lartë.
Can do this. Intentaste tragar a prova?
You do. You do. Yeah, mia. You do. You do. You do. You do. Test, test. You do. Prova. John. Test. You do. Prova, test, test. You do. You do. Test. Prova, prova. You do. You do. You do. You do. Test. You do. you do, test, prova, you do, test, you do. You do, you do.
Greetings, Ahmad. You can't see me, right? Camera. Oh. Greetings, Ahmad. How you doing? You're muted, Ahmad. Artur, I want you to meet a neurosurgeon from Afghanistan who's here. Ahmad, you're muted. You're muted.
Kemikte
Hello.
There's Ahmad. Yeah, you look good today.
Okay, thank you, sir. Hello, colleagues to Albania and Spain as well. Hello, good morning.
Does anyone else want to introduce themselves while we get some free time?
Okay.
See, Ahmed, you're using this platform well. You're meeting other people. You're meeting other people. And you will see those people in the future.
Yeah, thank you, sir.
Well, that's a good way to do it. I encourage people to use it like you do. Just reach out and say, hello, I'm John Bennett from Miami. And it makes a little, gives it a personal touch, you know. It's education, of course, but I mean, it's nice to have a personal touch too.
Yeah, sure. And I share that all the webinars and conferences with our colleagues inside Afghanistan. And day by day, our colleagues are interested and participate in conferences as well. And now we have also Dr. Yasin Rasa with us. He is a young neurosurgeon from Afghanistan.
Oh, good.
And the other colleagues will also join.
Yeah, you can start the grand rounds with just case presentations. That's all. I mean, nothing has to be nothing complicated.
Okay, okay. Yeah, we do, inshallah.
Okay, just let me know when you're ready. I know I keep hearing you. Saeed, I guess Saeed. Okay, very good. We start in about 20 minutes. Okay, Arthur, can you hear me? How are you doing? Can you hear me okay? No, you can't hear me? You can hear me? Arthur, are you there? Oh, okay. Okay, you do hear me. Okay. Oh, that's nice to see you in here, Margarita. We can chat. I mean, the conference hasn't started yet. We started about 14 minutes, Margarita. Oh, you don't have a microphone? Okay. You're coming to a knife fight. No, you're coming to a gunfight with a knife, is a phrase. Okay, Marguerite, I guess you can hear me. Now, what the responsibilities of a co-host, you don't have to do anything, you just watch, but once you get to know it, you'll be able to admit people into the room and you'll be able to throw people out as well as mute their audio. Sometimes people forget about the microphone and they leave it open. And it detracts from this presentation. So the co-host kind of mutes the people. You see on the right-hand side, there should be a mute the microphone for everybody. So you can just, let's see it, mute yourself, see what happens. Yeah, you just did it. You muted yourself. That's the kind of thing you do. When someone comes in from the panel, they come in from a smartphone, they don't know, they're on the run, they turn the conference on, but they don't put the mute button on. And you get the noise from the traffic from wherever they're at. That made Michael Lawton really mad once. Because right in the middle of the presentation, all this noise, traffic noise. a little disconcerting. I'm going to have some Albanian coffee.
It's very early in Miami.
Oh, there's Margarita. I hear you.
Ah, okay. I don't know if my microphone
No, it
is
works
working.
fine. It works fine. Yeah.
Okay, thank you.
So, okay, is Dr. Llanos all set?
Dr. Llanos has his talk about 11:30 after the break.
Oh, okay, let me screen share then. Hold on.
Second part in the
Hold
morning.
on. Let me get his. Let me get the schedule up here. Oh, okay. It's 11:30. Okay. This is the wonders of computers. Look at this, Margarita. You see the schedule? 11:30. Francisco Gonzalez Llanos,
Yes.
bypass.
Bypass, past, present, and future. Yes.
You see it?
Yes, it is. Yes, yes, please.
This ain't no disco.
Yes.
Okay, I'm gonna put the pin that up there. Good evening, mentor. Do you hear me okay? Oh, no, I have to introduce him first. Okay. Mentor, I have to introduce you. I'm Dr. Bennett, okay? Let's start again, okay? And I need to introduce you. You need to unmute. We need to start again, Artur, we need to start again. Yes, we have the video feed. We don't have the audio feed. Unmute, unmute.
Well,
Yes, yes.
If you have seen the program, we'll begin with some official presentation. That's the official opening of the meeting, and then later we're going to the scientific part of the meeting. And that now I invite to Professor Mentor Petrella to speak about the history of neurosurgery in Albania. Professor.
Okay. Thank you again. The neurosurgery in Albania started with the opening of the King Zog Hospital in Tirana in September 1st, 1932. This is the moment of the inauguration. King Zog met the American ambassador and he invited him.
Ainsi accède-t-il à la demande de l'ambassadeur américain pour accueillir les réfugiés juifs et leurs familles en Allemagne.
He invited many Jewish professors from the Jewish community that escaped the Nazi in Albania. That was a big moment. You see here the photo of the first staff of King Zog Hospital, and you see here is the neurosurgeon, Walter Lehmann, Schlesinger, Kastler, Nobel, and the others. They proposed to the king to open the Faculty of Medicine in 1937. But the contribution of Jewish professors in Albania was abnegated, and they have been expected and have been in limbo, as Dante's Infernos put all the pre-Christians. The only document that showed their activity is in 3 lines in the history of medicine published in Albanian medicine in 1962. Walter Lehmann was appointed chief of Department of Surgery in Göttingen, but he spent 3 months with Cushing after the report of then Brigham Hospital. He published 61 scientific papers and the first textbook of neurosurgery in German-speaking countries. Those are the documents showing the activity of the 355 professors that has been expelled during the Nazism. I found a secret report of Italian intelligence that has been scrutinizing the life of Lehmann during his stay in Albania. The neurosurgical activity of Lehmann started in 1936 in Vlora, but it was only head trauma. But in the King's Hospital, he had performed surgery in head trauma, spinal echinococcus, cerebral abscess, meningiomas, and unspecified brain tumors. We have the written report of his activity. He left the country when Albania was invaded by Italy 2 days before, and this is the letter that he sent to the director of the hospital of leaving all the instruments to the hospital. And those sets of craniotomy and laminectomy has been used by my professor Curti when he opened the clinic in Tirana. The letter that I received from 2 of his sons, Klaus and Hans, they stated he once said that his 3.5 years in Albania were the most fulfilling of his life. This is the memorial in our department, and we salute Walter Lehmann as the first Albanian neurosurgeon. During World War II and after, it was one of his assistants, Shiroka and Professor Jata, neuropsychiatrists, that followed the activity. And those 2, the surgeon and ENT, since the opening of the department that came later in 1964, it was my professor, Professor Curti. He was educated in Czech Republic for 3 years, and the department was 20 beds and performed surgeries with craniotomy for cerebral tumors, laminectomy, and with the tools that you see in the slides. After it was Dr. Adriano Spondi, who was educated in China for 1 year during the Cultural Revolution, but he brought the experience of the sitting position in posterior fossa and awakened craniotomies. This is the first intervention in microsurgery area of my professor Curti in 1972. The real microsurgery area started with Professor Jumari, who was my professor and my boss. He was educated in Lariboisière and he was chief of the university clinic for 10 years. In 1996, it opens the new department with 32 beds and 10 intensive and post-intensive with all the tools that you see. I've been educated in France, in Lariboisière, I have had the same residency with Bernard George, with Professor Hudar, Cofignon, Ray, and Jean Jean as radiologists. The caseload of intervention, elective, because we didn't have with the trauma to deal with the trauma, it's actually at 1,400 surgeries per year. The arrival of the new neuro-oncologist, Kaloshi, with assistant of in England, made it possible to have our experiences that has been presented in many journals on gliomas. Dr. Florian Dashi, who came from his education in PTA no, in PTA Salpêtrière, made possible to the introduction of intraoperative monitoring and epilepsy surgery. After it was our radiologist under the assistance of Emmanuel Hudar that in 2010 and after we have our unit of neuroradiology and interventional with coiling, stenting, and all the tools that they need. The department has his radiosurgery X-Knife lineup in 2011, and with the help and assistance of the Madrid team and Kita, especially Arthur started performing radiosurgery, and he has a good experience now. Dr. Ivana Lignetti, who was trained in Milan, is our guy in peripheral nerve surgery with this last publication, and the experimental laboratory that we have of microsurgery with our friends of Irish, with Jack McCain and Ridvan. We have every year the course of microsurgery for all surgeon, plastic surgeon, ENT, and so on. Also, Dr. Ivan Adenoid arrived with his experience from Milan, and the first DPS, it was in 2015.
Excuse me, doctor. Could you please share your screen? Could you please share your screen, please? Yeah, we need to see your presentation. You need to share the screen.
Yeah, sorry.
That's okay. That's okay. We're all new at this. That way we can see the presentation directly. Sorry to interrupt. There you go. There you go. Okay, better.
It's the moment when Henry Marsh came here, and we have had the experience of awake craniotomy. It was very well presented in New York Times Magazine by Carlos Ove Knosgaard. And we'll show you. The second unit of neurosurgery was installed in 1972 in Trauma Hospital by Dr. Kodasi. After it was Dr. Odashi, who is performing a good job with 500 intervention trauma and spinal surgery. The other department is the actual one, which is in since 2010, the American Hospital, with 10 beds, all the tools, and about 500 procedures per year. The newborn is this hospital of Memorial in Fear. It's a newborn, but two neurosurgeons are working there with these tools. I have been educated by my father, who was professor of literature, with the motto of Don Quixote. Because of my origins, that I have been considered a dirty aristocrat or dirty bourgeois but I was right when the society was wrong. And my career finished probably with more than 15,000 interventions with 1,600 aneurysm clips. Thank you. It's your turn. You can switch.
Thank you, Professor Petrella. This is the history of neurosurgery in Albania. We are a small country, but we have done a lot of things, and I'm very happy and proud to have been part of this department. Mr. Ambassador, Excellency.
Thank you very much. It is a true pleasure and an honor to participate in the opening of this very important seminar on the future of neurosurgery, along with Vice Minister Rakacholi, Drs. Ley, Urthaith, and Petrella, and very distinguished professionals and researchers, authorized scientific voices in their respective fields. I thank them wholeheartedly for their presence here today. I would like to also express my fond appreciation to the Spanish and Albanian societies of neurosurgery, the American Hospital, and Dr. Salabanda, a dear friend of Spain. Thank you so much for fostering this excellent initiative. Throughout my career, I have always felt like a diplomat amongst academics and an academic amongst diplomats. Although it humbles me to be among such authorized scientific voices, since I have developed my academic career in an entirely different discipline, EU law, international relations. I did have the privilege of working for 1 year as a senior fellow at Harvard's Belfer Center for Science and International Relations, where I acknowledge heuristically the extraordinary synergies between science and diplomacy. There is, of course, a value of diplomacy for science, diplomatic efforts that further scientific research, and history affords innumerable examples of this dynamic, from the UN's climate efforts to combat climate change to today's initiative in the field of neurosurgery. But there is also a value of science for diplomacy, scientific efforts that bring together communities, building bridges between nations and peoples. And I am firmly convinced that today's initiative epitomizes also the extraordinary value of science for diplomacy. I thank you once again for promoting this excellent initiative. I remain at your service always for contributing to building bridges between our nations, our scientific communities, and I wish you fruitful sessions ahead. Thank you very much.
Thank you, Ambassador. Thank you for your words. We promise that we'll continue to make this scientific relationship between Albania and Spain. Excellency Vice Minister Rakacholi.
Thank you, Peter. Honorable Ambassador, distinguished guests, and dear colleagues, it's a great pleasure for me to be here on behalf of Ministry of Health and Social Protection, and on behalf of Her Excellency, our Minister, Madam Manaseliu, who apologizes for not participating here today because of her agenda, but in this case has given me this honor and the privilege to be here in this very prestigious event. Sorry, but because of the protocol, I have a representative from the Prime Minister here. I am going to continue to speak in Albanian. Natyrisht që niveli I neurochirurgjisë shqiptare është tashmë një realitet I prekshëm, është një realitet I prekshëm jo vetëm në Shqipëri, por edhe në gjë. dhe ne fatmirësisht jemi të gjithë dëshmitar të kësaj. Profesor Petrela, si zakonisht, bëri një ekspoze të shkëlqyer të historisë së neurokirurgjisë shqiptare dhe tregoi që nëse ne e kemi këtë rezultat, padyshim që është merit në radhë të parë e burimeve njerëzore që kanë punuar këtu, patjetër që do të veçoja vizionin e profesor Petrelës, por natyrisht tregoi që janë rritur të rezultate sepse siç ka thënë Toni, janë ngritur mbi shpatullat e të modelit. Rezultate, zoti ambasador, vuri theksoi një moment të rëndësishëm, lidhje ndërmjet shkencës dhe politikës. Dhe natyrisht që shkenca dhe politika padyshim që shkojnë së bashku. Shkojnë së bashku sepse politika patjetër që i hap edhe rrugë shkencës. Dhe padyshim që nuk do të kishim ne sot këto rezultate që ka neurokirurgjia shqiptare, ashtu sikurse dhe arritjen që në përgjithësi mjekësia shqiptare në këto vite ka, nëse edhe nga politika nuk do të kishte pasur interesim dhe nuk do të kishte pasur mbështetje. Sepse për mua që kam dhe 30 vjet në shërbimin mjekësor, për një pjesë të mirë të kolegëve që janë këtu, e mbaj mend se si ka qenë edhe se sa me shpejtësi kanë arritur investimet në shëndetësi, investimet në neurokirurgji dhe ne kemi arritur të jemi në nivelin bashkëkohor të ndërhyrjeve dhe të mënyrave të diagnostikimit, jo vetëm në rast të parë kuptohet nga mendja, në rast të parë kuptohet nga investimi në burimet njerëzore, por edhe të aparaturat kjo do të ishte pamundur. Dhe do të thoshja që ka nesër në një shpejtësi jashtëzakonisht madhe. Ne jemi dëshmitar që në vitet 90 ne nuk kishim asnjë skaner, sot kemi rezonanca. Kemi rezonanca jo vetëm në Tiranë, ku aktualisht janë 4 të tilla, por kemi rezonanca po flas vetëm për shërbimin publik, kemi rezonancë në Vlorë, kemi rezonancë në Korçë, kemi rezonancë në Fier, kemi rezonancë në Shkodër. Investimet e mëdha janë bërë në të gjitha infrastrukturën spitale, dhe sepse nuk mund të eci një shërbim i vetëm pa ecur e gjithë shëndetësia shqiptare. Dhe unë besoj se një pjesë e mirë që unë shoh këtu vini nga zona të ndryshme të Shqipërisë, dhe kemi parë se si ka ndryshuar pamjen spitaleve, kemi parë se çfarë investime madhore janë bërë në infrastrukturë, çfarë investime madhore janë bërë në aparatura mjekësore, siç e theksoi profesor Petrela sot në Spitalin Memorial të Fierit, që për një viti ofrohet model terciar për shumë shërbime, përfshirë edhe në kirurgji, dhe të mos harrojmë që në të gjithë këto vite, shëndetësia shqiptare ka qenë në vëmendje të zhvillimit shëndetare dhe në radhë të parë ka qenë në vëmendje zhvillimit të burimeve njerëzore. Sot, nga profesor Petrela tha që shërbimi i neurokirurgjisë u hap me 20 veta, sa neurokirurg kemi ne sot të shpërndar, kemi neurokirurg që punon jo vetëm në shërbim, por kemi neurokirurg që mund të punojnë edhe në vende të tjera ku ka hapura spitale neurokirurgjie. Dhe Ministria e Shëndetësisë dhe Qeveria Shqiptare vazhdon të bëjë investime, jo vetëm në drejtim të hapjes së horizonteve të reja të studimit, hapjes së fronteve të reja me kushte bashkëkohore të punës, por edhe në drejtim të pagës edhe të burimeve financiare. Janë rritur pagat për shërbimin shëndetësor shqiptar, janë rritur 60% vitin e kaluar, janë rritur 3 herë brenda një mandati, dhe brenda këtij mandati këto paga do të rriten edhe 200%. Natyrisht që duhet i bëja, kita thonë thotë që duhet ta mbyll, do ta mbyll, por kur filloj të flas për sukseset e qeverisë shqiptare, nuk mund të rri sepse janë aq shumë natyrisht që më vjen mjeti për mua, sepse do të marrë me punën e përditshme, me harrojmë që sukseset e punës së përditshme janë të lidhura edhe me atë. Ju uroj shumë suksese në punën tuaj, ju siguroj për mbështetjen e qeverisë shqiptare dhe natyrisht falenderoj kryesisht një spanjol që kemi këtu, duke siguruar një vazhdimësi bashkëpunimi. Ju falenderoj.
Thank you, Excellency Vice Minister. And I beg your pardon, but we have to go forward. It's an honor for me to invite the President of Spanish Society of Neurosurgery, a friend of us. He was, he liked so much to came to Albania, and I am very proud to be his friend, and I'm very proud to have our Professor Luis Rey here in Tirana. Bienvenido.
Okay, we need to share the screen, please.
No, it's not.
You can close.
Good morning, Excellency, Madam Vice Minister, Excellency Mrs. Chano, Ambassador of Spain, President, Professor Mentor Petrera, Professor Salabanda, dear neurosurgeon colleagues, ladies and gentlemen. It's an honor for us to be here with you today. I would like to thank, on behalf of the Spanish Society of Neurosurgery, on behalf of this representation of society, and on my own behalf, this extraordinary invitation to share knowledge with the Albanian Society of Neurosurgery. We are deeply grateful and honored for your kind invitation and enormous hospitality. For 2 endless years, our professional interactions have been limited to telematic contacts, losing something that in medicine we know in a special way how important it is. We have lost the human contact. The transmission of knowledge can be done in many ways: books, recording, teleconference, but nothing is better than different transmission, than eye contact, than human contact. Thank you for making this face-to-face meeting possible. I am sure that this meeting will be the beginning of a great friendship between our societies. I speak on behalf of the Spanish Society of Neurosurgery, and I put at your disposal all the resources of our society to establish ties that I am sure will be lasting and profitable for both societies. I am grateful once again for the opportunity we have been given to discover the beauty of this country and the kindness of the Albanian people. But I must also admit that it's very difficult to refuse anything proposed by my friend, Professor Kita Salabanda, who in addition to being an excellent professional, is a great ambassador of his country and was committed for a long time to discover this wonderful country. I conclude by thanking again you for the hospitality received, with the certainty that this meeting will be fruitful and will bring enormous benefit to both neurosurgical societies. Thank you for everything. And this is a present for you, the President, Mr. Petrera, Dr. Petrera. This is the Spanish Society. I'm sorry. And this is for you, and you are
Thank you.
invited every day and for all your life to come to Spain, please. I don't know, it's very easy. Take care. No. It's not a big present, but it's a very good sign. Thank you very much for everything. Thank you.
Very important. Thank you. The last slide, I was like Don Quixote on.
So I am Central Plant.
Yeah.
Thank you.
Well, we now begin with the first scientific part. Professor Luis Rey will moderate this part. Thank you, invited authority, for coming.
I think that the first speaker is. Okay, perfect. Yes. that one. Yes.
Put it on the presentation mode. That's perfect.
Hello again. I have to introduce myself. I am Luis Ley. I'm the head of the department of Hospital Ramon y Cajal in Madrid. And I am going to talk about the management of brain AVMs. I'm trying to do a rationale about the treatment of this disease. I think that all of you know what is an AVM, so I'm going to be very quickly in this part. This is not a very rare disease. It's more frequent than we think. And important thing is the most of the people, the patients, translation. Okay, are younger than 40 years old. When we are going to treat a disease, we have to know if there is any evidence of how and when treat this disease. And if we look at Cochrane library, we cannot find any evidence about how to treat AVMs. And this is because, brain AVMs are different people from people, and there are many ways to treat AVMs. I usually don't use videos on my presentations, and people say that if you don't have videos, it's because you don't operate. This is a surgery that is not very complex one, but this is to show you this is an interventricular AVM where we use the neural navigation in order to look for it. This is just a case. Okay, if we don't have any evidence about how to treat AVMs, we have to investigate, to research about the natural history of the disease in order to know which is the best treatment possible. And when you review the natural history of AVMs, we found that the most important thing is hemorrhage. So if we are able to know which is the risk of hemorrhage, we are going to know which is the risk of the disease. In a very simplistic way, we can calculate the risk of bleeding of an AVM with this formula. But in this case, you have to know two things: that you are thinking that all the people has the same risk. This is independently if it's a young one or is an older one, and that all the AVMs have the same history. That is not true. If we if we are going to research about the natural history of AVMs, we find this first paper from the Finnish people. Finland is a very curious country in which every case is centralized, so they are able to know perfectly what happened with the people. And they tell us in the 90s of the last century that the average risk is 3.9 of hemorrhage and 1.0 about death. But 20 years after, a new paper tells us that that's not so true. The risk is about 2.4%, but there are many risk modifiers. And the risk modifiers are the most important thing because they will be able to show us how to treat each one of these patients. The risk modifiers, as you say, is the risk if the AVM has rupture or not rupture before the admission of the patient, the size of the AVM, the location of the AVM, and the type of the venous drainage of the AVM. But we can think that this only happens in Finnish people. Like you can say, well, Finnish people is a very strange people that live very near to the North Pole, and that only happens to them. But if we look on the literature, we found that there are many papers that saying the same thing about the people have a bleeding presentation, about the size, about the location. So we can, with all those data, we can see that it's very difficult. There are many differences between all the AVMs. We have some patients with a very low risk of hemorrhage and patients with a very high risk of hemorrhage, depending on where is the AVM and the type of the AVM. But also, we have angioarchitectural risk. It's not the same risk in a patient with an intranasal aneurysm or with a fistula. And we have also to take care about the time evolution. This is the same AVM with 4 years of difference. In the left side, we can see that it's a very small one, probably easy to treat, and in 4 years later, the AVM is a nightmare. Well, we have to know also about the morbidity of hemorrhage, and we can see that this is a bad disease. And with all those things, we know now which are the risk factors, and we know now how bad is the AVM. We can say that probably we have to treat all the young people with AVMs because they are more prone to bleed. We have to treat all the ruptured AVMs because are the most risky. We have to treat deep and posterior fossa AVMs, or probably we have to treat all AVMs because they are not a very good disease. And now we have to compare it with the treatment of AVMs. We have the best treatment of AVMs. They should have to have this characteristic. This is the second part of the video. Okay, no worry. Okay, and we have many different possible treatments that are microsurgery, radiosurgery, endovascular surgery, and combination of these treatments. Probably wait and see can be a possible treatment, but only in very few people. If we look at microsurgery, this is another AVM. We have some pros and some cons. The most important pros are we can achieve a complete occlusion, an immediate occlusion, and a permanent occlusion in one simple surgical procedure. But it's aggressive. People are afraid because we are going to open their head. Has some constraints about eloquency, about size. Has some surgical risk. The patient can develop an infection or can develop any other thing and needs some time of recovery. And it's surgeon dependent, not very much, but it's surgeon dependent. We can know which is the surgical risk because we have this tool that is the Spedler-Martin scale that is perfect. It's perfectly reproducibly with all the surgeons. We can see that in grades 1 and 2 the risk is very low, and a very important thing that is very easy to take this to have these outcomes in a good skilled neurosurgeon. This is very reproducibly all about all the neurosurgeon people. Some years ago, Lawton modified this scale, and we are able now to know much better what is the risk of a surgery. Endovascular surgery has some pros and some cons. The main pros are that is size independent and eloquence independent for this treatment, but some problems about that many times they need many procedures to do the treatment, and we don't know about the stability over time of this treatment. And moreover, it's very expensive and it's much more surgeon dependent than surgery. Endovascular risk can be calculated for this formula that nobody in the whole world used. So we don't know which the real, we are not able to calculate the risk of the procedure. But if we look at the literature, the outcome of the people that tried to cure the AVM is very bad compared with any other modality of treatment. We can see morbidities and mortalities very high in people with small nidus for like this one, or in this case that we have a mortality of 3% with a cure of 53% and morbidity of 8% in patients with not very big AVMs. So I think that endovascular treatment is not a very good treatment to do alone. What about radiosurgery? Radiosurgery is minimally invasive, is independent of eloquence of the AVM, and is ambulatory, but has some cons that there is not immediate occlusion, is volume dependent, and has some constraints about the risky organs nearby. But also it's true that easily reproducible. We can calculate the radiosurgical risk with formulas, and moreover, we can calculate the chance of obliteration with this formula. So there are some advantage of radiosurgery above all the rest of the treatment. The outcomes is about a rate of occlusion at 3, 4, and 5 and 10 years, about from 58% till 93%, with a risky bleeding during this time that it remains, and is the most important problem of radiosurgery. And we have also adverse radiation effects that are so high as 10% in the series of follow. But there is true that there have not been any induced neoplasm. Sterler and Ponce published this report that is very artistically, it's very nice to put these images, as you can see. And they established that the best way to treat the AVMs are in class 1 is surgery, that is groups of Sterler and Martin 1 and 2 AVMs. Class B, combination of both procedures, and class C, do not treat because the risk of the treatment is higher than the natural history of the AVM. What about combinations? We can use embolization plus surgery if we want to decrease the volume and intraoperative bleeding through embolization of deep feeders, but it's very important that you don't have to embolize preoperative any AVM that you are able to operate with embolization, because the only thing that you are going to do is to increase the morbidity. Use only if it is necessary. Use it only if you have an aneurysm that is outside the AVM and you can lower the risk, but don't use embolization routinely. Embolization plus radiosurgery have some advantages. That the main one is decreasing the volume and to remove the risk factors with people, for instance, people with a deep AVM with aneurysm. You can treat the aneurysm and then treat with radiosurgically the AVM. But also it's true that decreases the possibilities of AVM closure. So probably the people, the endovascular surgeon that is going to embolize the radiosurgery, to embolize the AVM must be the same that have to treat radiosurgically the AVM. And radiosurgery surgery, that is a rescue now, decreases the volume, makes it surgery easier, but has a high latency period. But I think that we have to think more and more about this possibility, because once an AVM has been treated by radiosurgery, it's much more easy to operate it. So probably this therapy will have more and more important in the future. In summary, both surgery and radiosurgery are effective for small AVMs occlusion. Surgery is about 5% morbidity in grade 1 and 2. Radiosurgery has a risk in these cases, but radiosurgery should be better in deep small AVMs and in brainstem AVMs. But surgery is better for small ruptured AVMs. And embolization, as we told, is better to remove risk factors as an adjuvant therapist. About big AVMs, we can say we agree that it's better don't touch them because the risk, the natural history is not so bad, and the probability of morbidity or mortality for the treatment is much more higher. So the choice of treatment can be something like this. If rupture and the patient has a grade 1 or grade 2 Sterler and Martin AVM, probably the surgery is the best choice. In grades 3, 4, and 5, try to do combinations of the treatments. If young rupture is symptomatic because seizures, try to do a medical treatment of the seizures, and study the possibilities of surgery or radiosurgery, because if you treat the AVM, probably the seizures disappear. In case of progressive neurological defect, you have to treat the AVM. And what happened about symptomatic? About asymptomatic AVMs and Aruba, I'm not going to speak of Aruba. I'm going to speak about this paper that appears some years before Aruba, and this is the beginning of the Aruba treatment. And this is the invasive treatment of unruptured vein arteriovenous malformations is experimental therapy. This is a neurologist who say this, and he said this because in a study of people during 5 years, they found that the risk of hemorrhage or any other thing was worse, was better, sorry, than the treatment. But it is very well answered in this other paper that that it's important to remember that 5 years of follow-up in 1,000 people is not the same as 20 years of follow-up in 250 people, even though the number of passengers is the same. Put in another way, even the most aggressive neurosurgeon will be unlikely to treat a patient with an asymptomatic AVM if the patient was known to have only a 5-year expectancy. And this is the most important thing and the best criticism to Aruba study. Okay, I am finishing, don't worry. The chance of surviving intact hemorrhage-free 25 years after the presentation of an AVM in a grade 1, 2 with conservative embolization, radiosurgery, and microsurgery is this. So microsurgery is much better, assuming an average risk of 2% that we know that is not so true, but we can establish this. And grade 4 and grade 5, also in selected cases, if you have to treat them, probably the best thing is combined treatment much more than conservative treatment. So the decision making, you have to look at the patient characteristics, you have to analyze the AVM characteristics, and then combining both things and knowing what you are able to do in your department, you have to customize the best possible treatment. As a conclusion, high-risk and bled AVMs should be treated aggressively to avoid great hemorrhage, and ruptured AVMs should be treated accordingly and considering patient and AVM idiosyncrasy. Microsurgery and embolization are both surgeon-dependent, and radiosurgery is more predictable. And the decision-making process should be carried out by a multidisciplinary, very well-balanced unit. This in these departments must be a very good endovascular surgeon, a very good surgeon, and a radiosurgical facilities in order to be well-balanced and to find the best solution for each patient in each individual case, and no more. Muchas gracias a todos. Thank you very much. I think if there's any question. Thank you very much. Well, I think.
Sorry, but can you define who is the best surgeon?
I think that
it's a very, very important question because it's I must say very instructive for all our young residents. But they have to know that if you don't have a good surgeon.
I think that the good surgeon is one who knows his own limits, and he has to look for the best of the patient. When you are a young neurosurgeon, sometimes you think that you can operate everything and say, okay, I have seen Hadis Nemi or González Llanos or any one of us operating an AVM or you, and I think I can reply that. But you have to think one important thing, that if you look at a very good surgeon doing a complex surgery and you think that it's easy to do that, it's not because it's easy, it's because that one is very good surgeon. So you have to think, oh, well, I am so good surgeon like that, with honesty, because we sometimes compare with pilots, but pilots go into the airplane, so if something happens into the airplane, the pilot dies. But if in surgery, if something happens bad, the patient dies. So you have to think always on the patient and be very, very honest with yourself and with the patient. And I think if you do that, probably that surgeon will improve during time and will be more and more specialized and will be a great surgeon. Any other question?
Thank you for your
your excellent speech, but I see you follow the AREPA suggestion for the follow-up of the patient and for the treatment of the AVM. But I am an endovascular radiologist, and I want to know which is your protocol for the follow-up of non-hemorrhagic AVM?
It's a very good question. Well, as I told, different AVMs have different risk factors. So the first thing is to do a very good angiography and look if there is any risk factor like aneurysm, like fistula, like any other thing. If there is a risk factor like aneurysm, we treat the aneurysm or treat the fistula and look for the risk of the treatments and how is the patient. If the patient is a young one, healthy with any other problem, and we are able to close the AVM, my opinion is we have to treat the AVM. And only we have not to treat the AVM in few selected cases in very old people with a lot of comorbidities or people that refuse any treatment. I think that now, if there is not a huge AVM, grade 4 or grade 5, and the patient is young, the best thing we can do is treat the AVM. We have many tools to do it perfectly with not a high risk. More questions? Yes, one more.
So I'm not a neurologist and a surgeon, but I'm curious, what about lifestyle in those cases that you treat medically or wait and see AVM?
That's a good question, because during many years, people have said that don't do any effort, or even in pregnant women say that you have to go to a C-section because you have an AVM. That's not true. I always say, well, try to don't laugh or go to footballs or go to any place. You have to do your normal life, because if you are not able to do your normal life, you have to be operated. So I think it's common sense. There are more questions? Perfect. Now it's my pleasure to introduce Arthur Sumari, that is going to speak about minimally invasive neurosurgery. Thank you.
Perfect.
So thank you very much for the invitation. It's a pleasure to be in this joint meeting. I'll try to speak about our experience in the minimally invasive neurosurgery. So as Howard has said, the most important person in the operating room is the patient, as already mentioned. So we have tricks, we know things to do, but we have to ask ourselves, is what I'm going to do is better for the patient? It will serve for his best. So what's a minimally invasive surgical procedure? Is a procedure which is safe and which has a lower postoperative patient morbidity. If we cannot do it in less time, in less costly, or it's not safer, it's better not do it at all. And why we are now able to have this minimally invasive surgery, neurosurgery, because we have better instruments and we have a better industry. And we have also to know that these procedures have a learning curve. So we are not best at our first attempts, but we have to learn to be better and better after each procedure. You don't do this procedure because you know how to do it, but you have to be sure it's safer for the patient. And during our work, we have to produce facts that these procedures are equal or better in results as the conventional procedures, can be done with less trauma, are less risky for our patient, and maybe has a cost reduction. So I reviewed some of my latest cases, and the first one I wanted to show is this hypertensive hematoma in a 55-year-old lady. Okay, okay. Who came with a left hemiplegia and a volume of 50 cc and a Glasgow coma scale of 15. After 12 hours of conservative treatment, she became Glasgow coma 6, and the hematoma had progressed. So I made a small craniotomy 2 by 2, and I managed to evacuate the okay. I don't know what's happening with my video. Sorry. Okay. So I managed to reduce the volume by 90% and to make sure that she didn't die from that brain hemorrhage. And this by a very small craniotomy, so a very small cortical incision, and no surgeon-induced damages. The second one is this clear multilocular abscess in a 44-year-old female which is being treated for multiple sclerosis for some years. And suddenly she developed headache and lethargy. So we have this abscess, multiloculated. And the first thought is to have a great craniotomy, frontal, to try to have this evacuation. Maybe if I go here, I might have a possibility to have all the cavities drained one by another, which is linked to perform just a very, very small craniotomy, which I did. I'm showing the bar hole using a microscope. I managed to evacuate this is the immediate postoperative MRI, where there is some residual pus only the bottom. And after medical treatment also, we have this maybe 6 months follow-up MRI showing only the sequela of the abscess, but no surgeon-induced sequelas. Trigeminal neuralgia, it's a well-known disease and have many possibilities of treatment, beginning with the medical ones. But when you have a patient who is refractory to the treatments, you might offer them the decompression. And I tried this endoscopically. It works. It's this is my first procedure. I had the endoscope in my left hand, and the free hand without holding devices. I'm trying to open the cisterns to have some CSF evacuated. And here is the fifth nerve and the vestibular here, opening the arachnoid. Lead down the vein, which is left intact. We're using some instruments not especially devised for this kind of surgery, but nevertheless, they work. Here is the arterial loop, which was evident in the MRI, but also this vein, which is just in the dorsal root entry zone, and which is probably this one responsible for the vascular conflict. So I'm trying to dissect and to make possible these structures are apart from each other, and I'm not able to move from fast forward. And this is the incision, a very small incision, just 1 week after the intervention. And she experienced the same relief as the others experienced from the conventional surgery. So it's a procedure with less trauma for the patient and equal results as the conventional one. This might not be the classical example of minimally invasive neurosurgery, but to be able to remove a tuberculum cella meningioma through the nose, I think that you put your patient in less risks than in the conventional one during craniotomy. If the anatomy of the tumor allows. So he came to us with this visual defect. To perform this kind of surgery, you need a good ENT surgeon, which luckily we have, Dr. Aga. So endonasally, the flap for the reconstruction, anterior fossa, some neuronavigation just to be sure what we're looking at, the drilling of the anterior fossa, carotids, optic. This kind of interventions converts cranial base meningioma to a convexity meningioma because you approach it from the point of attachment. So you devascularize and you have the opportunity to remove this nasal component of the tumor, which is not possible from the intracranial route. So we are opening the dura. And now we're looking at a tumor which was very hard. We're trying to make some kind of debulking, but in fact we're using those cutting devices for the bone of the septum. You can see the nevertheless, slowly. We tried CUSA, but same thing. A very little possibility to debulk. So finally we arrive at the arachnoid plane and we preserve it, which enables us to remove piece by piece and to be able to protect the perforators. You will see the optic nerve on the right here. We are lucky enough the left nodule came out easily. If not, we were prepared to leave it there. You see the left optic a little bit. Now it's better seen. Again, the dissection is very slow and carefully. We know the meningioma has always this arachnoid membrane over it, so if we take care to have that membrane, we are always sure to not do damages. So let's be a little bit of meningioma going out. Now we are taking the infundibulary stalk and the attachment to the diaphragma cella, and we are removing the meningioma from there. A little bit of meningioma in the optic canal on the right, which we're trying to remove. We're opening up the optic canal and removal of that fragment. And finally, it's an inspection on the lateral margin. We thought we saw a little bit of meningioma staying there, the olfactory nerve, both optics, chiasma. And a very important part of this kind of operation is the reconstruction of the anterior base. So we put fascia and then some fat, and after that the gasket seal technique with the second layer of fascia and a part of nasal cartilage. And to support of all this, we have a nasal septum flap, which was prepared at the beginning. We haven't used any fibrin glue or something sealant, any sealant material. But after the flap, some Surgicel and Posicept and Marocel to put all together, to keep all together. He didn't have any leak, any meningitis, and his vision improved slowly during the follow-up months. His vision was becoming better and better. So we did him a good service with the Simpson 1 resection. Another one case of minimally invasive neurosurgery, this dermoid cyst, mesial, large, but if I go supraorbital, I have very little brain to transgress, and then I am in the cavity. So that's what I did. It's an eyebrow basal frontal craniotomy. At the beginning, I tried to remove as much as possible using the microscope, but after removal, it became clear that I wasn't able to remove all the cysts. So I converted to the endoscopy. I can't fast forward the image. So now I'm using the endoscope, also free-handed. I'm trying to enter the corticotomy I have already made. And now I have a much better view, which means I'm much more sure of what I'm doing, which means the patient is safer from my actions. And now you see very clearly the carotid and the A1, and in the upper part of the screen, the optic nerve. And so slowly, much safer, I'm trying to remove every part of this dermoid cyst. So this is my patient just 1 week after the intervention. This is the craniotomy. And the MRI, which reveals the total removal of the dermoid cyst. So in conclusion, we have to be safer, but less trauma for the patient. And probably this is the future of neurosurgery. And I thank you very much.
Thank you for those very nice pictures and videos. Well, one thing I sometimes I do scrub base as well as spine, very little now. But I remember when I started doing endoscopic super 7 Germans, with a few with the endoscopic approach, and I found that we lost more than one. One invisibility, vision, and control, but we lost the smell and sister lips, as you know, is a big issue. Do you still do all of this to the same approach, or you go very on also appropriate sometimes?
Yes.
For this particular case.
Yeah, I mentioned a little bit in the presentation, but you have to be very careful in selecting those cases. If you have smell and you think you can't do total removal, then it's better not go that way. So it's but if you have a patient who says, I don't want my cranium to be opened, so you go this way. You have to be ready to offer the patient the best, which is something you decide together. About the rate of leak, we haven't done so much meningiomas, but craniopharyngiomas we've done, and we had a leak, but it was the hydrocephalus. It was not our cranial base repair the problem, it was the hydrocephalus which we didn't see at the beginning. So valve resolved it.
After you said about that, last report published in DNS, the last report of Carral, all the group, large experience, and all the people followed that and said that, okay, we will do that. But at the end, the editorial comment was, don't do that in meningiomas because you will lose passion and you will become like Cushing with transfemoral. That was the conclusion of the editorial. Many people will follow what Carral said in the group of that have the most experience. But in meningioma, be careful.
You have to be sure to remove all that dural tail, which you can't remove from the nose.
It's the main problem. So when you speak to the patient, you will say that you may die.
Of course, I agree, but I fear that first I would say that 95% I've done this kind of tumors microsurgically, but I have my doubts now, serious doubts, because okay, smell is okay, the possibility of a leak is very dangerous, but for me many times the most important thing is vision. And in the end, I almost always open the optic canal when I do microsurgery. And the problem is I seldom see people opening the optic canal when they do microsurgery. And I seldom see a tumor without entering the optic canal. In the same way it entered in your case.
Yeah.
Right? In your case, the right optic nerve was almost ruined because it had a lot of tumor, was very compressed. It's very difficult to do it with microsurgery. So I think in the future, vision will be the most important factor, more than smell. It's very important. They are the two most aristocratic nerves, not coming from the brainstem. Smell from the encephalon and the vision for the side from the encephalon. But it's much more important vision, I think. So I think I'm starting to think that endoscopic is superior to microsurgery for preserving vision, and this is important.
I think as in AVMs is the same kind of thought. You might have both. You might need both procedures, depending on what you might operate today via the nose, and in 3 years you have a recurrence on the left side of the optic canal, and you go transcranially, and it's not a failure. Thank you.
Thank you very much, Rosemary. Very nice presentations. And now it's my pleasure to introduce Professor Lafuente, that is going to speak about MIS, No Way Back. I have it here. We have some technical issues, but are going to be fixed in a few minutes. If you want, we can shift the order, and I think it's good. How long? 2 seconds. Okay, 2 seconds. 2 Lafuente seconds. That can be 5 to 10 minutes.
No way back. System. Yes. Sí, la próxima. Sí, los dos. Déjalo pasar. I'm sharing or not. Okay, thank you very much. I'd like to thank Kita. I can see him now. I don't know where he's for organizing this fantastic course initiative. He insisted too much for us to come. Unfortunately, COVID didn't allow it, but now after his insistence and also with Mentor being our counterpart in Albania, this has happened, and we're happy to be here. We started to visit your country. We love your country. The people, very Mediterranean, same ways like in Spain. And also I'd like to thank Mentor for being a mentor, not only for Albanian neurosurgeons, but also for European. He's been very much involved on bringing with the latest ENS course, which happened a week ago, bringing Albanian neurosurgery and putting Albania in the neurosurgical European map. So thank you, mentor, for being so good at this, and I hope your residents and your faculties and your friends are also proud of that, what you have achieved. Finally, you have achieved also that the Spanish society comes as an invited society, and Luis has said nice words for you, and we are very happy and honored to be here in Albania. Anyway, so I'm going to talk now. Arthur was talking about minimal invasive surgery in neurosurgery, and I'd like to talk about minimally invasive spine surgery. No way back. Is a change of paradigm between what it was before. Spine has always been regarded as the lesser brother of neurosurgery, but I believe that although neurosurgical procedures in the brain require of high technical ability, spine is a more challenging subspecialty because it's very difficult to get the indication right to operate. So this is very challenging in spine, and this is why some of us want to be more involved in spine. Anyway, so now we have minimal invasive. Okay, now, yes. Yes, so as surgeons, we are, during our careers, we need to embrace new surgical approaches. We have to embrace and know new technology and adapt. This is a high demanding society which are very much adapting to social media. They look at it, everything, they read about everything. And this becomes a problem. Before they came, they trusted you blindly. You did what you thought was best for the patient. Now they get very much information in the social media, and then that can give you limited. That means that the visit before was very clear, now becomes like a conversation between two specialists. So this is also important when you start and you're at the end of your career, that to start a new practice and changing a paradigm is also complex and difficult. So what I believe on the spine surgery, minimally spine surgery, is that it's supposed to be better, is modern, is a new thing, is cutting edge technology for skilled surgeons only, is facilitated clearly by image guidance and robots, and this is what Arthur was talking about. The development of new technology has allowed and helped this to happen, and we need to define what is really minimally invasive. I think he's done that so before, and I'm not going to expand on that.
Excuse me, doctor.
What is the compromise? What are the compromises of the minimal spine surgery? Well, the compromise on the compression, they say that maybe not as much. Compromise of the strength of the construct. Also compromise on bone graft and fusion. Maybe you don't put bone graft as you do in open procedures. And compromise on exposure of tumor removal. These are the critics of the old school to the new school surgery, spine surgery. Let me show you, this is a graph of Rick Fessler, one of the fathers of minimally invasive spine surgery, on how he has managed to do from 1990, when he did all the procedures in an open way, up to 2006, where he has turned over his practice onto minimal invasive. This has happened because he particularly has been very crucial in developing technology to be able to do these operations. Him and a group of surgeons, typically American, but someone from Brazil and so forth, and he's managed to achieve this in 16 years. What are the advantages of MIS? As he has shown and proven, well, there's less pain, there's less blood loss, there's less hospitalization, early, quick return to work, less physiological stress, of course, fewer complications, even though they think the same or similar fusion rate, which I don't believe particular, and preservation of the normal function, which is the key issue in this case. So what are the advantages of minimally invasive spine surgery and the disadvantages? We will talk about the advantages, but the disadvantages remain down to 3. It's a steep learning curve. The operating without the anatomical visualization, which the old school so-called, are used to. We want to see the anatomy and act upon that. And this reduced space limits this visualization. And also radiation has been another issue, or one counted as disadvantages. So what are the advantages? Well, minimal invasive, if anything, preserves muscle, ligaments, and bony structure, which prevents delayed instability. And I think this is a key issue to try and implement minimally invasive spine surgery, particularly when you're talking about degenerative spine surgery, which is 90% of the practice. You can apply minimally invasive in all other spine surgery, like tumor removal, intradural. You can do also in cervical, and I'll show you a few cases. But particularly in degenerative, when you open up, you remove or you distract the muscles, the ligaments, and you need those to help on the recovery for the patient. So this is a case, this is a synovial cyst, as you all know, and this has been regarded as a highly unstable lesion traditionally. And how was the management? Was this a lesion? This is a facet joint problem. This creates listhesis. The disc starts to fail as well. And this is the case. This ends up with some subluxation or listhesis, grade 1s typically. This is some of the intraoperative pictures. And we ended up doing this traditionally with an expandable cage, screws, reducing the listhesis, and an incision such as this on a patient which will recover, really, to be honest, in between 6 months or a year. Can we do something else? Well, I do now for this particular disease, like synovial cysts, even though they have grade 1 spondylolisthesis, we detect this, we identify the medial part of the pedicle, and we find through a little hemilaminectomy with a drill, and you can get as much view as this over here. And this is a case of a synovial cyst where we've treated it unilaterally, and I'll explain why I mentioned this, through a 2-centimeter incision. And this is the video. I hope you can see some of it. This is drilling the synovial cyst on my side. Okay, no working. Okay, this is lateral, this is medial, this is the drill drilling the facet joint. This is cranial, this is caudal, and this is where we drill there. We find the synovial cyst ipsilaterally. We don't have to go to the other side. Fortunately, this doesn't work. Oh, this does. Okay, so now this is medial here, lateral, drilling the facet, caudal, cranial, and we will see the synovial cyst showing here. This was a small one up there. This is the dura, and this is here the synovial cyst showing that's the synovial cyst, and we'll remove it, and that's the end. Now, what do I do? Sometimes when the synovial cysts are very, very big, you cannot identify the dura, and sometimes you have trouble to see what is what. It's for that matter now that we approach the synovial cysts contralaterally. So we come for a synovial cyst on the right, we go through the left, and we can go and the bone, the lamina contralaterally. We remove the yellow ligament, and then you will see clearly, because the synovial cyst grows from the joint to the midline. You will see the plane very clearly. You will distinguish the synovial cyst. And once you've punctured it, you remove it, you can get easily from the contralateral side. So that's my practice now. So what are the economics of the minimally invasive surgery? Well, clearly it's cheaper, but it has to be done properly with the right technology, because if you leave a hemilaminectomy and not decompress in canal stenosis a complete patient, you will have to take him back to theater, and then the economics fail in this matter. So economically is better, but you need to do the procedures correctly. So what are the disadvantages? Well, we know that the learning curve is always an issue, but I don't think now with the new technology that this has been facilitated. And also one of the main key issues is, what do we do when we can have a limited, through a hole, through a tube? Of course, we cannot see the whole anatomy of what we want to do. We need to move the hole and so on. So it's very important, if something is not going right during the operation, or you cannot see properly, don't insist, stop, look at the MRI, look at the X-ray, because you need to know something is going on and you don't realize. Okay, so very careful with the visualization. And also radiation. Well, we know that the radiation, and this has been proven through many articles that there's more radiation when you do minimally invasive surgery than when you do an open procedure. But this, of course, has now changed dramatically with the 3D acquisition of imaging and also with robotics. And it's clear that many of the authors will argue, particularly the old school, that this is too much radiation for you. However, if you have to do according to the radiation that you normally do during a percutaneous screws or minimally invasive surgery, you will need 2,700 procedures continuous to reach dangerous concentrations of radiation in your body. So this is not going to happen anyway. However, you need to look after this and, of course, minimize the exposure to radiation as much as you can. And now you have the technology to do so. Also, this is another case. Is a gentleman with a listhesis and stenosis of the canal, and this is how we can do it and manage it in some occasions. We can perform on a lateral position, also minimally invasive procedure, and then go and do percutaneous in the same setting. This was done by us once we didn't have robotics. Now, I still don't have it, but when you have robotics, you will be able to put the 4 screws. I think 270-degree fusion here is enough. And I was quite happy with this case particularly. Some of the limitations, of course, if you cannot X-ray a patient, of course, you cannot do minimally invasive. Not because you're going to be shooting X-rays, but you need to have some acquisition. So some cases, you will not be able to perform these operations. You need to be aware of that. Well, about navigation and robotics, this has changed completely one of these disadvantages of minimally invasive surgery, as the radiation has diminished radically on that. And well, I don't want to go too much on that, but put the positioning of pedicle screws, one of the major complications that we have, particularly junior doctors who start doing these procedures, the violation of the media of the pedicle can cause damage into the nerve root. Sometimes it's irreversible damage, sometimes it's reversible. But this means that you need to have another operation, remove the screw, reposition. And this has been trying to minimize this. And we're talking about 10% to 15% of patients that will require new surgery to reposition on the screw. However, even using, this is a study, well, even using the navigation, and this is a system KIC2 from the PUI Synthes group. And this is very easy and very affordable for any unit, even the private sector. However, the Aero is a much more complex and very expensive, but also this gives you 3D acquisition imaging with navigation. And this, of course, you're supposed to believe this will be the ultimate tool to prevent violation of pedicle, and this is not true. Sometimes you can have also some problems with the pedicle screws, particularly when the pedicles are very, very small. I mean, you cannot go against anatomy. You can try and make your trajectory as best as you can, but sometimes the pedicle is not big enough, and you have to go out, in, out, and that goes to the body, and that should be enough. So the intraoperative AO provides you a very, very good exposure, and very, very good to, particularly to do scoliosis, and particularly to degenerative or idiopathic, doesn't matter, but complex spine surgery, and this technology has now improved and gone to cervical spine too, and this has made a huge difference. Going to some of the studies, this is by Royal Hartle, who had been doing this with the Aero, and as I said, is not free of violation. You have a 9% compared to 15% free hand, but in this situation had zero deficit on the, there were very small violations, they had to remove them, but there was no neurological deficit. That's the only advantage, which is important, of course. What do we do with the lumbar interbody fusion? Now navigation allows you to organize the direction of the cage. As you can see, you can, how we're going to put the cage through this small hole. You protect the nerve root over there, and you can do this in a small hole about 3 or 4 centimeters. This is a big change also. This is a can be a triangle that we use on endoscopic discectomies, but also accounts for this. And as soon as you are lower in the disc and posterior, you will not hit the nerve root, which is the main complication of inserting a cage, particularly the banana cages. Another issue where we use the minimally invasive surgery and has been very, very determinant is sacroiliitis. This is a very complex disease, very difficult to diagnose properly, and sometimes it's overcharged. The solution for that was to fuse sacroiliac joint, particularly uniting to sacro-lumbar fusion. But this new instrumentation through navigation allows you through very small incisions to set up 3 little rods, which are made by titanium, and fix the sacro and the ilium, causing a reduction of the pain quite significantly. Here, for this particular disease, the most important thing is the right diagnosis, because sacroiliitis, you should be first trying with infiltrations, and if they have a positive infiltration test, then you think this is the cause, therefore you can go and undergo this operation. Other things we are using now is Adenoid and Scoliosis, the tethered new system. You go laterally and you can go all the way up, particularly idiopathic with a flexible scoliosis in adults, in idiopathic scoliosis. You put these screws on the bodies and then you can put the tethers and reduce the scoliosis. And before, scoliotic operations were hugely aggressive and invasive, with losses of blood, tremendous loss of blood, and very nasty looking incisions, particularly for girls, that they were worried about cosmesis. Now with these procedures, you can achieve the same, even better results with a much better cosmetic result. And through a little 3 or 4 centimeters, you can put screws in 4 levels, and you can do 3 or 4 incisions, and this looks very elegant and very good too. So robotics, we all know about robotics, very expensive. I think robotics now are doing not much more than the 3D precision images do. But I think robotics we need to learn the robotics techniques as we will be able to do, and I don't think this will be too late. We'll be able to see it, how we can design a laminectomy through a robot, and we'll press on the pedal and the robot will do the laminectomy for us. And I think this is not very far away, but for that to happen, we need to be familiarized with the robotic techniques, and that's why we, some of them, not me, I have the robot to put medical screws, but compared to 3D acquisition, the results are not very different at all. So it's a huge investment if you just want it for that. So what about C1, C2? Well, we all know about the importance of the posterior muscles, the occipital C1, C2 muscles, the rotator muscles. You see them here, 1, 2, 3, and 4. They give tremendous stability in the craniocervical junction. Sometimes when we want to do C1, C2 screws, we strip all those muscles away. I tend to not to do as many, even in an open procedure. Some of them take the whole, they peel the whole C2, as we have to do in many occasions. And this becomes, we fix the segment anyway, but those muscles are not only inserted in C1, which they are not, they're inserted on the cranium, on the occipital bone, squamous part, and this gives also some stability on C0, C1. And by removing these muscles and doing a C1, C2 operation, clearly will remove some of the stability of C0, C1. Although C0, C1 remains or bases the stability in bony structures, and is C1, C2, which remains the more ligamentous joint. I think removing those extra elements from the squamous part of the occipital bone is a handicap. So we need to navigate this hidden incision. If we tend to do this percutaneously, and you can see you put the star here in the C2, which is the biggest one. You cannot do it in C1, and then you map the points that you want to put in. Unfortunately, in this situation, you cannot put bone graft, which is very important to create and to provide this complete fusion, but certainly you drill the facet you remove in this operation. I never take the C2 nerve root, but if you want to do this operation minimally invasive, you need to remove C2 and drill the joint, so that will create a fusion by itself. This is how you put it. This is bilateral. You have to do it on both sides, And once you've done this, you put the screws, you put the rods, and that's done percutaneously with preservation of most of the middle line muscle structures. How about corpectomy for metastatic tumor? We all know, I'm familiar with the Patchell paper, which says that basically by people who were 2 segments, a randomized trial where the patients who had an operation did much better than the ones that didn't have the operation in the 1 and 2 year period. Rib sparing retrorectomy is not technically challenging, and you can do this particularly on those which are immunocompromised patients. Anterior column support means less posterior support necessary, although you have to be committed to do both, and the chest drains doing through a minimally invasive procedure are not always necessary. We have this case, you understand the balance and the destruction of the vertebral balance here, and this is how we tend to do this laterally or posteriorly through a thoracotomy or through a lateral side of the lumbar spine, through a lateral lumbar approach. But when you have a patient with multiple metastatic patients, and you have particularly this was a paralyzed patient, he was immobile and with pain, we opt for this small incision, as you can see. We have now technological advances like fantastic retractors, which put you, and you can anchor these retractors down to the bone. You can work with controlling vascular structures, and the duct also very important to prevent damage at this point. This is how we put the cage. This is how we put also through percutaneously cement other metastases which are not destroy the bone, but they're still there. We tend to put cement on them, and this is the incision of the patient through little incisions here percutaneously, and this is how it looks, and this is how the X-rays of the patient looks. So be aware on these patients when you have a metastasis. People tend to give radiation therapy, or people want to wait and see. This is a particular patient that happened to us. This is not the typical case, but you have this. This is not from us. This is from the Texas Back Institute, but this is a proof that not all the metastases behave like this, and you can have a situation where these metastases in a couple of months turn into this with a paralyzed patient, where this could have been dealt in a different way. This is another patient we had, a different level, of course. We have this retractor system, and look at the incision. This is what we put, and we go lateral and then percutaneous screws, all through minimally invasive procedures. Patients up next day and home in 2 days. So this is the great advantages. So how do we learn, or how do we teach this? Because this for young surgeons is easy, because they're starting to do, and I have some colleagues that were taught only in minimally invasive surgery, not in open surgery, but the hands-on courses are crucial to learn these techniques, and I invite you all to be involved in some of these courses. I'll show you some of them. We ran one in Madrid with Dr. Parajon, which involves all of these techniques with robotics and so forth, and it gives you a broad spectrum of the possibilities that the minimally invasive surgery provides you as a surgeon. Also, minimally invasive surgery can help you when somebody have a complication. They say, okay, we cannot do this openly. We need to do. We cannot do this minimally invasive. We have to do it open because this is a disaster. So this is a case of one of my colleagues in my department. He put a cage, standard cliff. Unfortunately, a year after the cage migrated, and you can see the cage here compressing the nerve root, clearly there and clearly there. And then we have to decide what was best to do. We were thinking going back, but opening the whole thing up. But then we thought differently. We went anteriorly. We removed the cage from the interior. We put a cage in the front, and we left the screws in the back. And so you can also sort problems and complications produced with one operation through minimally invasive. So minimally invasive is not only for a primary surgery, it can only be done for recovery or secondary surgeries. So what have I learned? Well, I've learned that you can improve your skill through a small tube. If you have to work in a 16 or 18 millimeter tube, clearly your skills will be much better. Also, I've taken the tube into apply into some of the brain operations. We've done intraventricular tumors using a tube, understanding that this is a very viable option to treating multiple, if not all, spinal cases. And also we need to listen to the critics, the ones who are not happy with the minimally invasive, because some of the critics are because they don't do it, but some of the critics are correct, and we need to look at them, not that they're jealous because they cannot do it, or they're lazy because they don't want to implement this for the practice. So some of the things we need to listen to them. So to conclude, clearly, and this is a standard and it's been proven, minimal invasive surgery reduces hospital stay and allows you to start working early, reduces muscle atrophy and ligamentous damage, reduces loss of blood and infection, because as soon as the shorter the incision, the less chances of infection there is. Minimal invasive is cost effective provided it's done properly and through a good training, and MIS is here to stay and there's no way back. And the reason is because technology continues to improve, technology continues to show us the path, and the skills are there. We are now working on 16 millimeters. We'll be able to work through small holes and do a lot of surgery, surgical interventions through these small holes, provided the technology is available to us and we are, with our demands, creating new technological advances at a faster pace. I'm a very keen American football player. I used to play in the Spanish league, as you can see here, but I was very keen on Vince Lombardi, who was the creator of the game. He said, perfection is unreachable, but only if we pursue perfection, we will achieve excellence. And I think I truly believe on that. This is one of the courses that I was mentioning to you. All welcome for everyone who wants to come. I'm happy to talk to me. And very important, we will wait for you in Madrid. We have gained the Neurosurgical Congress, the World Congress for Madrid 2025. Of course, next year, I also wait for you in Barcelona, which we will organize in the European Association of Congress. And I hope Albania is represented highly with fantastic research, fantastic cases, so we can all be there and join as friends. I know Mentor will be coming, Fatos, and the rest of you, Ander, I hope you'll be there. And nothing else. Thank you again for the invitation. It's been a great pleasure, and we'll carry on with the visit to Albania. Thank you very much. I'll take some questions, if there's any.
As a politician, he asked me, when you invest, it is not invasive, it's fantastic on the fashion side, there are prospects. But first investment, in how many years should be?
Well, it's a very good question. Not all of us. Yes, of course. Good. First of all the techniques come up, and this new techniques have to be proven. Once you've proven the technique is safe for the patient, once you've proven there's less complications, the patient go back to work early. Once this is properly determined, and that, for instance, a robot helps to these operations to minimize complications and so on, I think ultimately this will be a must in all centers, because they will find and they will do economical studies where they will prove that you have this technology, you will save money in other ways. So this will not be a hospital investment. This has to be a health authority investment. Okay.
Okay, thank you very much, Jesus. And we have now the coffee break, because the person who had to be here is not able to stay here. So we have some minutes for coffee break, and about, yes, in half an hour we can come back here. Okay, thank you.
I'm going to try because it's in bad. I'm afraid maybe Jesus.
Okay, Arthur, let's set it up. Hello, Dr. Llanos.
Maybe. This one.
The blue.
The blue.
We select this one. Shall I open it? Minha entrevista. É, né? Olha aqui também.
No, it was PDF. I have to look for the other one.
If there are no videos,
it is one. No, the problem is the videos. This one is the one we should open. Can you send this one?
This one.
Yeah. This is the problem. That's why I'm trying to fix this. And they will run because it's fine. But maybe they have to. So maybe.
No, doble al vídeo. Esto doble al vídeo y se sale. Pasa. Esto es un vídeo. Esto es un vídeo. No intentes apretar la flecha. Esto es el vídeo. Aquí.
Bueno, esto
Aquí, ya está. Estas dos veces.
Sí, pero si quiero adelantarlo.
No puedo.
Sí que puedo. Pero si no voy a
¿Cómo se puede adelantar? No, no te dejo.
Yes. Whatever you want. For the photograph, now the better. I remember. Let me turn on the light.
Y a ver la mía si anda. ¿La has puesto ya, no? Me la ha puesto. Solo veo un par de vídeos que hay. Creo que sale los vídeos que hay. Los vídeos que sacan. Pero mira, por ejemplo, entonces si los vídeos corren más rápido. Es el problema. Ah, que ahora la vídeo.
That's what they come from.
Very nice presentation. You can hear. Late, very late. At 2 a.m. because my flight was late. I came from Milan.
You haven't seen anything?
I came from Granada. No, good connection. Flight to Mallorca, then Milan. I organized that meeting. You were there in the dinner.
She prefers.
Mango, you know. Remember?
As long as she's not sleeping, I'm okay with that.
2016. 2016.
Yeah.
Bueno, pierdes la posibilidad de correr los límites.
Si te pones aquí en el celular,
tienes que
traer
sí, sí, pues hasta sí, no, bueno. Bueno, es lo que pierdes, pero vamos, hay que seleccionar cuáles pones y cuáles no. ¿Qué pasa? Se queda atascado. ¿Cómo es?
Anda con el ratón.
No, se queda atascado.
A ver. 111 diapositivas, compadre.
No, pero paso media hora, ¿no? Pero bueno, a ver. Se peta ahora. No sé qué es esto, tío. ¿Cómo está encima? ¿Cómo es?
¿Qué pasa?
Y en vez de decir que debe ser del TV, ¿qué haces?
No sé, solo por ahí.
¿Y se me engancha o qué? Es que lo mismo se me ha parasitado. ¿Qué haces? Pero está bien. ¿Qué? Está haciendo esto. Esto es lo mismo. Se mete. Margarita. Y entonces, ¿cómo con esto?
This is the first one. The Albanian, this is the Spanish for neurosurgery.
Vale, Ángel, ya tienes esto. It's okay. Yeah, of course. I'm moving out. Let me see. Escape.
It's because you are broadcasting for Neurosurgery guy. Great guy.
Stop the screen share and easy.
Yeah, of course. I know the guy.
Okay, the first thing you need to do is share the screen. Share the screen.
People to stay awake.
Primera etapa.
It's amazing.
Professor Jamari.
Share the screen.
Comparte a pantalla.
Yeah, but I need to share all the or just presentation.
Say, exacto.
But you share the presentation.
Can you hear me, Arthur? Can you hear me, Arthur? Perfect. Can you hear me? Can
Io do to show amazing video in seconds. Io organizzo e poi c'è un'impressione dietro, non c'è testi in video automatici su app diretta full screen.
Yeah. Hi, are you having trouble sharing the screen?
PowerPoint exactamente, ma sta loco.
Yeah, you need to, necesita compartir la pantalla.
Presentation, look at the presentation mode.
Arthur, are you there? Are you there, Arthur? Can anybody hear me? Can you hear me? Can you hear me okay? Okay, you need to share the screen. Compartir pantalla. Al fondo de Zoom. Compartir pantalla. Por favor. Share screen. Share screen. Al fondo de Zoom. ¿Dónde está todo? Okay.
Lo que te decían, tú que me lo comentes. No, que ya está, que nada, pero que no hay ningún problema, pero que no hay ningún problema, que yo lo tengo reservado la semana que viene, ¿sabes? Y que la semana que viene venga, un beso.
Okay, Arthur, can you hear me? Can you hear me? Hello, Arthur, can you hear me? I don't know if anyone can hear me. Can anybody in the conference hear me? Alguien puede oírme? Margarita, ¿tú puedes oírme? ¿Tú puedes hablar, Margarita? Okay. Okay, you hear me. You hear me, Margarita. I'm glad. Arthur says he's going to share the screen. So he's aware of the issue. Right, Arthur, can you hear me? No, I can't hear you, Margarita. Can you hear me, Margarita? Okay, let's just wait and see what happens. Okay, perfect. Looks good.
For the coffee break. And is Dr. Lama talking about bypass, past, present, and future?
Good morning. My talk is about the bypass. Bypass surgery has been very important and will be very important in neurosurgery, no matter what we think, but will be important because there are problems in neurosurgery that can all be resolved using the bypass. The title is about the past, the present, and future. I'm talking about the past. The first slide, you know, I showed you in July 16, 1969, the human beings got to the moon. Although some people still nowadays don't believe we've ever reached the moon, finally we reached the moon because we know it was very important for humanity because we know in part partly what we are because of this landing. We know our origin. The moon was a piece of the Earth, a celestial body the size of Mars, crashed with the Earth at the very beginning of the formation of the solar system, and the moon was formed like a piece of the Earth. We know that from that landing, we knew that the surface of the moon was very similar to the Earth. And now where it is on the rays, the rare elements, there are plenty of them on the surface of the moon. But more important, we put mirrors at that time in the surface of the moon, and with laser now, we know that we learned that the moon is getting away from us, it's escaping for us. It's amazing. But the maths explaining all of these discoveries is very simple compared to the maths. We need to understand the circulation of the blood flow in the human body. Aneurysms were made from the prehistory. We know the growth of the bone after a craniotomy. We need the speed of the growth of the bone after a craniotomy, so we can tell now from these paleolithic craniums that almost 50% of them survived. Of course, they were not doing bypass or complex procedure, but almost 50% survived. In October the 30th, 1967, it's not the photo of the Gassi Jasari performed the first bypass. And we have to be humble. I wouldn't compare the human beings reaching the moon with the first bypass. But the question is, how long did it take the humanity to reach to the point, to technical and theoretical point, to perform the first bypass? Almost the same it took to get to the moon. It's the only question. Of course, we have to be humble, and it's not the same for humanity reaching the moon with the first bypass. But it took a long time. And how was the history of the vascular, cerebrovascular, and microsurgery, what we need to reach bypass? If we go to the beginning, this is the Everest Papyrus. It's the first document in human history talking about vessels, arteries and veins. And they call they use the word met to describe the vessels. Suruta, an Indian physician, was the first to discuss about the importance of hemostasis. 600 BC. Then Hippocrates was the first to use the word apoplexy. Apoplexy, the result of the occlusion of a vessel inside the brain. It was Hans Chiari in 1905, the first to link, without any evidence at that moment, the occlusion of a vessel with the apoplexy. But Hippocrates, in the 4th and 3rd centuries BC, was talking about apoplexy. Herophilus of Chalcedon was very important because was the first to talk, this is a Latin translation, of course, to talk about the rete mirabile, the wonderful net, the collateral vessels in the base of the brain. Very important now, the study in the ischemia cases. Of course, they described many anatomical things because it was very important, but this was the first time in history we talk about the rete mirabile. Galen of Pergamon was very important because we further tried to explain the apoplexy, but was the first of the Occidental, Sutra, the Indian physician, was talk about that before, about the importance of hemostasis. Avicenna and Abulcasis in the Middle Ages were very important physicians. Avicenna wrote the Canon of Medicine, a very important book in the history of medicine. And Abulcasis was the first of talking about the ligation of the STA, the superficial temporal artery. You saw in the Middle Ages, he described the way of dissecting and occluding the STA in the Middle Ages. Then the revolution in the Occidental world came in the Renaissance with the Humani Corporis Fabrica by Andrea Vesalius. He described almost from scratch all the human vasculature and anatomy. And later, Thomas Willis described the circle of Willis. Gerard von Swieten, a Dutch scientist, was the first who proposed the mechanism of cerebral embolism and stroke. We're still in the middle, in the Renaissance. Then the history went on with the human drama, the human existences, because a lot of these breakthroughs in the treatment of vascular pathologies were made in war. During the 16th, 17th, and 18th century, most of the discoveries about hemostasis, treatment of traumatic aneurysms, and things like that were done in war, were military surgeons. And in the 19th century, Thomas Murphy was the first to perform end-to-end arterial anastomosis. Was a very, very important American surgeon. And then this is the man. This man is Alexis Carrel, which in 1902 described the triangulation technique to perform vascular anastomosis. This was the breakthrough, definitely, in the history of medicine, in to perform vascular anastomosis. He won, he won the Nobel Prize for this work. Now, in another word, in this Romuald Gegorsky, born in what is today Ukraine, now it's Ukraine is on the race because of the war, but in two wars, in the First World War, and then in the war between the Polish and the Bolshevik War, he performed 40 cases of vein grafts to repair arterial defects. First time in history. Again, the war, again, genius, treating to help his fellow countrymen. Then, in 1939, was the German Antafel performed the first encephalomyosynangiosis, an indirect way of revascularization. against the war and war and war. Gasmonid, another genius, developed the angiography, and now first time in history from the Egyptians, we could see from the inside what was happening. And now the theory, the theoretical approachment of Hippocrates, and then Hans Thierry in 1905 were proved. The occlusion of a vessel caused the stroke. The Gasmonid won the Nobel Prize, not for this, for other things, but. And then this, another genius, an American neurologist, was the one who could foresee the future. Maybe we will be able to perform a bypass and supply blood to the distal, vessels to the occlusion. Was Charles Miller Fisher, very important in history of bypass, this neurologist. In 1953, Michael DeBakey performed the first carotid endarterectomy, another breakthrough in history of neurovascular surgery. Then the microscope came. So far, the micro hadn't been used, but this was a Swedish otologist who introduced the microscope in medicine, and then this Theodore Kurz, an American neurosurgeon, introduced the microscope in neurosurgery. And then in the 60s of the last 20th century, in the same decade, the human beings were preparing to go to the moon. There was a schooling, especially in the United States, of improving the microsurgical techniques. And in Vermont, they developed the first laboratory for training and preparing microsurgery. They did a lot of things, along with Julius Jacobson and Suarez in Vermont. They performed the first embolectomy, the first anastomosis, the first a lot of things. And at the same time, in 1963, these guys this is Kunlin, the photo of the guy on the photo is Kunlin, Warringen and Kunlin performing nicely. They were very unlucky, because they are almost unknown to the neurosurgeons. But in 1963, they performed the first easy IC bypass between the common carotid and the ICA using saphenous veins. The case was successful, but the patient died. Successful technically, and the bypass was opened, but the patient died. That's the reason why everybody forgot this thing. But in 1963, a high flow bypass was performed by these two guys. Kasi Jasargil, the giant of modern neurosurgery, received news about the case of Warringer and Candling and wanted to improve. He was frustrated because in the 60s, he received a patient, a female patient with an occlusion of a vessel, and he couldn't treat the case. He was disappointed. He knew about the case of Warringer and Candling and moved to the United States to improve his technique, to microsurgical skills, and went to Vermont, of course. It was like the Lyceum of Athens of that time of microsurgery. And he performed, he trained, he surpassed them in technique, and was able to perform on October 30th, 1967, the first STA-MCA bypass. Then this changed the world of microsurgery, and came the golden 70s with a lot of very important people. Here you have the photo of Robert Spelberg, one of my mentors, who are genius of neurosurgery, and this is Lockheed. In the 70s, basically, they developed the original technique of Warringer and Candling. They improved the STA-MCA. At that time, in 1962, Jasargil performed the first STA-MCA in a moya case ever in history, a disease described by Japanese people some years earlier, but he was the first who performed STA-MCA bypass in moya. And these guys, Lockheed, Spedler, then Schund, Hausmann, they started to study the flow. They were conscious at that time that we will have to know more about what is happening inside the brain. It's not only a technical thing. And they started, along with the industry, they started to develop means to measure the flow. The xenon CT, and started to use the Doppler, the recent discoveries to be able to measure the flow. But then in the 80s of the last century came the trials. The trials, you know, there was a international trial of bypass for ischemia cases. And then in the 80s, it started in 1977 and finished in 1985. And the conclusion was bypass there is no point to perform bypass in ischemia because the medical treatment is better. We had but we had a problem at that time. We all know neurosurgeon cases, impossible to treat. They receive the maximal medical treatment and they start suffering strokes. What can we do with these patients? Some people started to, didn't agree at all with the of course, they believed the study, but they went on doing ischemia cases in these selected cases. And these people were doing well. So they repeated the study. At that time, when I joined the neurosurgery, most of us, the people around 50 or 60, started to work in this moment of history of neurosurgery. Failure of the first cooperative study, and waiting for the second study. And I attended to the development of this COS study, the carotid occlusion study, because I was in St. Louis going every year for these years, and people were very excited with this study. But in the end, the result was, again, favored the medical treatment. Why? Because unexpectedly, the medical treated patients behave far better than forecasted before. So we still have the same problem, but we still have these patients, these ischemia cases, failing the maximal medical treatment and still suffering ischemia. So we still have to do this. Now, of course, in Japan is synonym in vascular surgery of perfection, of at least pursuing perfection. They perform the JAM trial. We were waiting, and of course, for them, the result was positive, favored the surgery. But why? They were studying hemorrhagic cases in Moya Moya, only a few subgroup of patients. So the question is not solved, but we still have, all of us have people under medical treatment not improving. So we have to perform a bypass in ischemia. Then in 1993, other surgeons tried to develop safer procedures. This is Professor Turiken, other of my mentors. We are in his lab in Utrecht. He developed a non-occlusive way of opening the wall of the vessels. So with a laser, we put a laser on the wall of the artery, and the laser took out a piece of the artery. So we didn't need occlusion at all because we performed the anastomosis before taking out the flap. But the problem was the size of the openings and didn't allow us to work with the small vessels. The minimum was 2.6 and it was too much. 2.6 millimeters was too much. And we couldn't control the flow we put inside. So besides, it was very expensive and we quit this. Then, this is Fadi Charbel, another of the giants of recent vascular neurosurgery, developed the flow meter. Now they are developing even more convenient because it's somehow inconvenient, this model, but a device to measure the flow, because the Doppler is only a sound. It's okay. We know the aneurysm surgery develop our ear, like when we attend classical music, and we know if the flow is good or bad, but we don't have a figure, and we need a figure. I don't know, 13, 60 point something, because we know much more about the flow inside the brain. Now we need a figure. Otherwise, you can do bypass. And this guy, Fadi Charbel, developed the flow measurement, very important. We're using it. When I started neurosurgery, I did my military service in Spain as a frogman for the Navy. And this was the last photo I took from Cartagena, from the window of the house before joining neurosurgery. I still practice from time to time spear fishing, and what struck me when I started in neurosurgery was very similar to spear fishing, because we have to take a deep breath, and you do everything without breathing again through a small glasses. The same. It reminded me quite a bit to the situation we have in the microscope. Economy of movements, and what you see is through sunglasses. In this case, I trained in La Paz Hospital in Madrid, where fortunately we had a lab to train. It's very important if you perform bypass to go to the lab and train everything in animals, perform your skills before you go to the OR. It's very difficult to practice things in human beings. Unless you suffer, the problem, Warringer and Canlin suffered. The patient is going to die, and it's worth it. If the patient doesn't go well, it's worth it what we do. We can go wrong if the patient don't go well. Then thanks to this man, Salim Abdul Rauf, I could go to the States and improve with the best in the world at that time in bypass. Then, what does consist the cerebral surgery? What is the revascularization surgery? It's put blood from outside the brain inside the brain. It's okay. The blood inside the brain comes from in the supratentorial compartment comes from the ICA. In the infratentorial compartment comes from the vertebrals and the basilar. Okay. Most of the time we're using branches of the external carotid because it's in handy. It's very, but we can use more distal bypasses. But most of the time it's the same. And what we trying to achieve is a good result. And this is the example of what is not, what we don't look for, a bad anastomosis. If we are not very accurate, the intimal response, what Alexis Carril realized from the beginning, is that the intima is the most important part of the vessel when we perform anastomosis, because we have to achieve a perfect intima to intima, a position to avoid this kind of scarring in the wall of the vessel and thrombo. This was the problem from the beginning. So we have to be very accurate. You need a very, very focused training to achieve the basic technique to do this. Again, this is the man, Alexis Carrel, Nobel Prize for surgical research. Unique, almost unique in the history of medicine. And you see, he stated 5 rules. And if you see the point 5, approximate the intima code in order to produce as small scar as possible. This is still, when something is good, it stays there for, I wouldn't say forever, but for a long time. And you see the 5 rules of Alexis Carrel: avoid twisting and stenosis, continuous washing, use very fine and sharp and round needles, and approximate internal codes. It's very actual. When should we consider bypass surgery? We've been using bypass surgery for tumors. Now we seldom use bypassing tumors for several reasons, because we're using less invasive approaches, like you saw today. We used to, when I started neurosurgery in the late 80s and first 90s, most of us were using huge approaches, and from time to time we sacrificed vessels. And then radiosurgery appeared, and many cases are treated with radiosurgery. So in skull-based surgery, the best revascularization, like Osama Al-Mefti always say, is the best revascularization is preservation. But sometimes we have to repair vessels. We will see in cranial-based tumors. But we don't prepare cases for bypass. But we still use in some cases of ischemia, is the second field of bypass. And especially we are using in aneurysm surgery. Nowadays, if you want to become a cerebrovascular surgeon, it's impossible you devote to clip aneurysms or to treat with aneurysms if you don't master the bypass. you need to master at least some kind of bypasses. What can the bypass offer to the patient? Only two things: flow augmentation, flow replacement. Flow augmentation, if there is not enough flow to a region of the brain, we provide through the bypass flow enough to this region of the brain. This is flow augmentation. Flow replacement, we cut the flow to a region of the brain because we have to put the, I don't know, ICA, MCA, whatever, and we put blood in this region of the brain through the bypass. This is flow replacement, or both. Sometimes we need both things. What types of bypasses do we have? We talk about 3 generations. Now Michael Lawton is talking about 4 generations, but it's only a technical issue. I stick to the 3 generations. Very easy. The first generation, the original STA-MCA. We get a final branch of the external carotid artery, especially the STA, but could be the PPA, the posterior, the PAA, the posterior auricular, or the occipital artery, or even the middle meningeal artery, distal branches, or occipital artery, distal branches of this, and put directly to a branch inside the brain. What just did, this is the first generation, and this provides flow augmentation. The second generation is what Warringer and Kuringer started, and then Spetzler, Hausmann, Schön developed in the 60s. Is put a graft with using vein grafts, or saphenous vein graft most of the times, or in my career I used mainly radial artery because several reasons, not the point in this talk. And this provide high flow bypass because the flow was very high. It was physical. We will see now why. And the third generation bypass is the intra-intra. The preacher of this third generation bypass was Michael Lawton. We are on the spot, we have a problem, and we solve with vessel inside the brain. It's very important because the first 2 generations provided us with possibility of flow augmentation and flow replacement. Of course, we take for granted that the 2 first types provide also flow replacement. But the third generation is a local solution. So it only provides flow replacement, but not flow augmentation. The flow is what it is. We cut, I don't know, a superior cerebral artery or a PCA in a surgery, and we put it together again. It's the same flow. It's only flow replacement. Okay, important to take into account. This is the positive law. I told you that taking us to the moon, the maths of that is Newton was a genius, but when it's the typical thing that is very complex to imagine, but then to explain is very easy, the Newton laws. To try to explain mathematically what is happening inside the vessel is nowadays impossible. Maybe with quantum computers now, because we need modeling, will be feasible in the near future. But so far, it's been impossible. The most close approximation to what is happening is very old. Is the Hagen possible law. You know, Hagen was performed some experiments in the 30s of the 19th century, trying to explain the stationary laminar flow. What is this? It's a fluid that is incompressible and uniformly viscous. They call that Newtonian fluid. Going through a cylindrical tube of constant circular section. This is not exactly what is happening. Our arteries and our veins are, because of the pulsation, are dilating. This mathematically is a nightmare. It's impossible to change. But the closest approximation we have is the possible law. What happens in possible law? Look at this. This law, what tells you is the flow we have through a section of a vessel, of a tube, not a vessel, because the vessel, because of the pulsation, dilate. If they are fixed and the viscosity is uniform, we have the radius on the numerator elevated to the 4. So the radius is our friend. The larger the radius, the higher the flow. And we have in the denominator the length of the vessel, and this new letter, this means the viscosity. So we have a friend, the radius, and we have 2 enemies, the length and the viscosity of the bypass. So it's very important, very important to have the patient hyperventilated and with high tension during the bypass. You can be the best in the world, you can be a Spätzle or Rokuya Tanikawa, and the bypass will occlude if the pressure is low, I can tell you. So, according to the possible law, the bypass needs to have a good inlet, to be as short as possible, and to have a good outlet. These are the most important things. And this comes directly from the possible law. Does anything influence the blood flow besides enlarge the radius? Because so far, the only thing we could do, we as surgeons, because the anesthesiologists can put higher the pressure, lower the viscosity, and it's okay. But the only thing we could do is to perform a short bypass, as short as possible, and enlarge the radius. The only thing we could do. And in the last years, we started to know more things about the bypass, not only the radius, because it's important to the vessels receiving the bypass. And we started to study the flow in the receiving vessels. And important is the current capacity of the STA, of the donor vessels. But it's very important, this concept, the integrity of the MCA network. It's not the same. Depending on the case, our brain is more prone to receive blood than in other cases. And when the vessel doesn't want to receive blood, it's very dangerous sometimes. And they come the hyperperfusion syndromes. And this is because of the integrity of the MCA network. The current capacity of the MCA, there are a lot of things, I will skip this, but it's very important. Depending on the type of bypass we perform, how we prefer, the diameter, a lot of things. But this is what I tell you, the MCA network. Besides the parameters of the possible law, we have the quality of the MCA. I'm talking about MCA because most of the time we bypass to the MCA, but this applies to any vessel in the brain. The quality of the MCA network determines what happens with the bypass. You see, this is a good situation. When we see this is a good collateral network. We perform STA-MCA and we get blood down to the M2. This is a good collateral network. If you see this after a bypass, this is right after the bypass, we perform, we know no problem is going to happen. But sometimes we get this. We only get flow in the angiography after the bypass, very close and very diffuminate around the bypass. Very dangerous situation because it carries risk of bleeding or infarction on edema. Absolutely independent of the possible law, because it's the quality of the recipient vessel. Treatment indications nowadays in bypass, in ischemia for bypass, progressive ischemic symptoms and evidence of inadequate CDF or CDR and no contraindication to surgery. Now we can measure with MRI or with CT functional, we can know the transient, the mean time and the flow, and we decide based on that and the clinical. Of course, cases not responding to the medical treatment, the international treasure that. But our first goal, at least in my experience, is the bypass. Is the aneurysm surgery, excuse me. The complex aneurysms from time to time require bypass. In my service, we are quite surgical. Of course, we embolize a lot, but we operate a lot, and we need bypass in some cases. It's very difficult to define what a complex aneurysm is because it would depend on the surgeon. It would depend on the situation of the surgeon. It would depend on the many factors of the patient. But for me, the objective definition of a complex surgery is an aneurysm that is difficult to treat without risk to the patient. No matter who is operating it, and if we have here an aneurysm in your team, and you are trained in treating aneurysms, if the lowest risk is not complex. If the risk is high complex, but it's complex. So, but times we have to follow, to treat the aneurysms, the principles of vascular microsurgery. What are the principles? Clean and atraumatic dissection, proximal vascular control, and respecting the perforators. This is the, if you can do this, if you can achieve this, you can safely operate on a patient. The first thing for the young people, our young colleagues, you have to do is follow Gassi-Jasarhill, and the first thing before be training cranial base and things like that, learn how to navigate the cisterns. It's the first rule in vascular surgery, clean and a traumatic dissection. We're here opening a Sylvian fissure, treating a MCA and a common aneurysm. And the first thing you have to know is to cleanly open the chiasmatic cistern, cleanly open the cisterns to deal with. In this case, for example, open even the interhemispheric fissure, very important in ACOM aneurysms. You have to learn, you have to master this. Atraumatic, you have to get to the aneurysm atraumatically. The first goal of the 3 is achieved. So if you can't do this first step, don't go ahead in vascular microsurgery. Then the second thing, the proximal control, like you see here, we control A1, and now we put a clip in the aneurysm. The next question: what defines a cerebrovascular surgeon? We are all men are equal, no? The illustration statement. But we have differences among us. And the differences are our anatomical knowledge, our microsurgical skills, and experience. Experience alone is very important. Experience alone saves a lot of things to the patients. It's very good. Anatomical knowledge, vascular skills, and experience. And forget about the rest. Of course, we have to be humble, we have to be sensible with the patients. But I think most of these things, even your parents can teach you that in your education at home. But the anatomical knowledge, the microsurgical skills and experience should be yourself, you alone. Why an aneurysm is complex? Because of the size, the quality of the wall, and the localization. Of course, the size is the most important factor to become an aneurysm complex. And this is the reason why we're doing bypasses most of the time, because of giant aneurysm. The management of complex aneurysms, of course, needs skills in vascular microsurgery and screw-based skills. Now I'm starting to talk about cranial-based surgery. It's impossible, I told you before, to become a cerebrovascular surgeon nowadays if you don't master bypass. But it's equally impossible to become a cerebrovascular surgeon nowadays if you don't master at least part of the cranial-based surgery. Of course, endoscopic is another issue, but you should master a lot of things. The proper drilling of the lesser wing of the sphenoid, perform a proper CTA approach, retrosigmoid, perform middle fossa approaches, the Kawasa approach, of course, the far lateral approach to the pike aneurysms. Without a skull base, is no vascular surgery today. And then a third thing, commitment, physical and mental work. Why? Especially for the young people. Because most of these things happen at night, because aneurysm, unfortunately, they rupture. And we have to be prepared to go there. There are very good surgeons that can afford to do this, because they have a lot of operations. To be a cerebrovascular surgeon is like to be a monk. You have to be ready for the patient. It's that clear. Aneurysms comes when it hurts, at night, on weekends, things like that. Microsurgery techniques for complex aneurysms. Of course, reconstruction with clips, very important. To be able to reconstruct an aneurysm very fast, lowering the transient occlusion time. Careful handle of the temporary clipping, of course. Clipping strategies with fenestrating clips, and then the bypass. We reach the bypass. Sometimes it's impossible. Even if we master the clipping of the aneurysms, it's impossible without bypass. One example, in many centers, most of these aneurysms are referred to embolization and put a flow diverter. This is the question is this a complex aneurysm? Very small, paraclinoid, but true ophthalmic aneurysm, dorsally pointing aneurysm. This is not a complex aneurysm at all in this case. And this is what we do. We need to master the cranial base approach. We've taken out through a mini-interional approach, a very minimal invasive approach. We took out the anterior clinoid extradurally, and now we're opening the distal dural ring. This is what you have to master of cranial base to perform a surgery on this aneurysm. You see, we're opening the distal dural ring, and once we achieve that, of course, we have in all the paraclinoid aneurysm, I perform proximal control, one of the rules in the neck, always. No matter if I can control the ICA in the clinoid space, in what we call C3, no matter. I always control that from the neck. And when you have opened the distal dural ring, it takes time. Now we are assessing the ophthalmic artery very accurately. We can preserve the ophthalmic artery. We open the distal dural ring, and you put the clip. You don't need bypass for that in this case, because it's very simple. The quality of the wall is quite good without calcium, and the size is not that big. Very straight clip from posterior to anterior. At an last, you look at the craniotomy, very, very small. It's not a complex case. Reconstruction with clip. Unfortunately, in our fight against the aneurysms, we don't usually have this clean situation. With a clip in the neck, what you imagine when you're a resident, you solve the situation. In large aneurysms, the goal is to minimize the temporary clipping, but reconstructing with clips. What we'll first do is to put a pilot clip that allows us to take out the temporary clipping and then go on with the reconstruction. And in these cases, sometimes we perform prophylactic bypass. If we foresee a long occlusion time. What is a long occlusion time? If the blood pressure is higher, really high, 20% more than the regular pressure for the patient, it's very difficult to see a patient developing changes in the neurophysiologic monitoring, the motor or the sensory potentials, going up to 15-20 minutes. We very seldom see that. You raise the blood pressure and nothing happens. Of course, we don't go to push the patient to that moment. And if we foresee a 20-minute occlusion in a giant aneurysm, we perform that, performing 3 small 6 minutes occlusion and opening, because it's absolutely different. It's much safer. But we don't go, I don't want to go beyond 10 minutes. If I'm going beyond 10 minutes, and with my experience, I can foresee when I'm going to need more than 10 minutes, I put a first generation STMCR, whatever, bypass prophylactic, and the situation changes. Now we have a case, this giant ICA aneurysm with occlusion test not tolerated. On test not tolerated, but with collateral circulation, coming from the ACOM from the other hemisphere, and coming from the PCOM from the posterior circulation. So it's a quite good situation. But we have asymmetry in the venous times, in the BTO, in the balloon occlusion test, and the patient didn't pass clinically the BTO. So in spite of the fact that we have collateral circulation, we can't occlude this ICA because it's a matter of time, this patient suffers a stroke. So in this case, we have to put a prophylactic bypass, because I don't know for sure when there is calcium in the wall, and with this size of aneurysm or ICA aneurysms, we don't know for sure that if something is going to happen to the patient. And unfortunately, I learned this failing with patients. With my colleague here, we suffer a very you don't forget these cases, you know, because you feel that you have the situation solved, all the neurophysiologic monitoring is okay, everything is okay, but in the end fails. And it's as easy, and with this size and with calcium in the wall, put STMCA, and everything changes afterwards. Now, in this case, I didn't know before if I would be able, this is the situation I told you, we have collateral circulation from the right, this is a left aneurysm, from the right side, from the ACOM, and from the vertebral, from the posterior circulation. And in this case, what we did was the same. We prepared the neck for the suction decompression, because in this giant ACA aneurysms, we have to aspirate and debug the aneurysm before doing the clipping. Prepare the superficial temporal artery, you know, to do the aspiration. We prefer that to go from the carotid, because of we suffer in several cases in dissections, especially when you come from the internal carotid. And we perform the bypass. Now we have controlled the neck, prepare the STA to the superficial temporal, the superior thyroid artery to perform the aspiration, and was the STA MCA in place. So we are ready to go and look for the aneurysm. We perform the stradural approach. We take out the anterior clinoid, open the distal dural ring, as I showed you in the video, and then start to widely open the cisterns to reach the aneurysm. We reach the aneurysm, and we try to dissect to get the proximal neck of the aneurysm. We try to dissect it from the ophthalmic artery, but because of the size, of the quality of the wall, because of the calcium, we have to perform the suction decompression from the neck. That's what we are doing here. And we perform the suction decompression. I see and I reconstruct the aneurysm. But I realize that the only thing I can do is to occlude the proximal neck, because it's impossible to take out all the aneurysm without leaving a Redman. It's not the point in this case. And the bypass was enough and to supply the blood after occluding this. And I will show you this is the suction decompression. And this is the situation after the bypass. You see a lot of flow coming from the other side. You see, we have occluded the carotid, but it wasn't enough. And you see the bypass here. You only need this, but without this, these patients will suffer a stroke, left side, aphasia, hemiplegia, disaster. So a simple bypass in a complex aneurysm, but impossible to do without the bypass. In other circulation, for example, in ACOM aneurysms, where we have giant aneurysms, we have to go to the third generation bypass. It's very difficult to put. Sometimes we did it, but it's very. You need to violate one of the rules, one of the lessons of the post. We have to be. Sometimes put the two branches of the fissure to reach the distal anterior communicating artery, anterior cerebral artery, the pericallosal artery. So in these cases, we perform a lateral bypass, a third generation, only flow replacement. Like in this case, actually, I've operated on several of these giant aneurysms, and sometimes it's amazing, but there is collateral flow, and you can trap the aneurysm. In this case was sent for friends from Córdoba, the south of Spain, to Madrid. We operated in there, and we could reconstruct only with a simple clip. Of course, we use the interhemispheric approach, anterior interhemispheric, to do aneurysms. But in this case, it was impossible. It's a larger case. In this case, almost always there are A2, actually A2 aneurysms, never A1. I don't know why, but this giant anterior communicating region giant aneurysms are always a bit A2, so you can trap the aneurysm without risk to the perforator, distal to the ACOM, what I mean. But in this case, you have to trap this and there is no collateral flow. What we did is a lateral anastomosis through interhemispheric fissure. What happens in these cases is that the size, the bulk of the aneurysm is lifting the vessel for you. So it's not that deep. It's easier. Its nature helps you in these cases. In this case, we perform a lateral, and you see I will put you the ICG. You see we've trapped the right A2, and now the flow is coming from the left A2, and you see we have coming from the left A2, we have flow in both A2s. This is a lateral third generation bypass. We've used this is a giant MCA aneurysm. In this cases, this case was complex because I will almost skip this case, but we have three furcation. The STA only have 2 branches. We could do several things here. Combine a radial graft for one of the 3 branches and use both what we call a double barrel STA bypass to the other 2 branches. But in this case, look at this. These arteries here are almost kissing. And what we performed here was a bypass to one branch, a bypass to other branch, and then a lateral to the 3rd branch with one of the 2 branches. And in this case was enough. I will skip the ICGs. And then we go to the perforators in anterior circulation aneurysms. This is an M1 aneurysm, one of my favorite topics. The M1, this is a rupture case, came to Toledo to our place, and it's a very nasty aneurysm, partially calcified, you see. And the problem here is we try to occlude this. We have to provide a bypass distal for the MCA territory, okay. But the problem here are the perforator themselves, the lenticulostriate arteries along the aneurysm. We know anatomically that the lenticulostriates come from the inferior and medial sides. And most of the bulk of this aneurysm is dorsal. So maybe what we can do here, of course, we need a bypass. We see both branches of the STA are feasible, around 2 millimeters, more than enough to perform the anastomosis, and prepare the plan. First, we perform a first anastomosis, STA anterior branch to the upper trunk of M2. We're putting the temporary clips here, open the vessel, you see. We're working in the Sylvian fissure. Very important, the technical issues here. We need aspiration because we don't want a messy. If there is blood in the field, you have problems. You open the artery, then we perform the second anastomosis. The STA, posterior branch, the parietal branch, to the inferior trunk of M2 trunk. So perform a double barrel. You see, we point the bypass, the toe, what we call the toe of the bypass proximally, and we do a running suture. You see, I perform the posterior one from the inside because I'm trying to get a bypass as short as possible. You see, with the nose, we run the suture. We already performed the other wall from the inside. This is what Michael Lawton calls the 4th generation bypass. But for me, it's a 1st generation bypass. We perform the anastomosis, of course. And then once we have 2 bypasses in place, we can go proximally to achieve the proximal control. What happens in these huge aneurysms is that we can't get the proximal M1. It's almost impossible. And we start to get proximal control to go into the ICA and to the A1. And we first the first proximal control. But if something happens in this step, and believe me, it do happens from time to time of bleeding of this giant aneurysm, you can control it. We put the first clip in the ICA. We put another one on the now you will see on the A1, and then we don't have problem in the distal circulation because we have blood coming from the MCA and from the bypasses, but we have to start reconstructing the aneurysm. And we put a distal clip to trap the aneurysm. At this moment, the lenticular striates are at risk because they don't receive flow distally. Now we check that with the Doppler that the aneurysm is not receiving flow distally, and now we aspirate the aneurysm. In giant aneurysms, you need several aspirations because for several reasons, for small perforators or even for the vasa vasorum, the aneurysms refill again several times. Now we are starting to work in the dorsal side of the wall of the aneurysm. You know, refilled. It's always the same with giant aneurysms. Again, we trying to shrink the aneurysm through aspiration, and I am starting to see. I reveal the dorsal wall of the aneurysm with bipolar, and I start to see the lenticular striates to control them. You see, because they are inferior medial and at this place here. This is the second, and then with the aneurysm tract, you know, we are remodeling the dorsal wall. Why don't we occlude proximally and leave the things like they are? Because otherwise it's more difficult for the lenticular striates not to have problems. Let me see if this is, no, I have to go to the next one. This is the situation after reconstruction. What with this is to reconstruct the aneurysm, and let me see if I have, no, it's the same. Okay, this is the situation. We have occlusion, proximal occlusion in the end because we couldn't spare it's a sick vessel. We don't want to leave this vessel open. But we just don't put the proximal vessel and leave it alone. We also reconstruct the wall of the aneurysm, and you will see why. Because this is the situation. If you leave the distal aneurysm open, the refilling from the bypass will create a problem. They sometimes even grow and rupture afterwards. You see here we have flow to all the perforators, and you still see distally the M1 reconstructed, but with proximal occlusion. Otherwise, with the combination of these two techniques, wouldn't be treated. This is the situation, you see. And now, from posterior, I will go from posterior fossa aneurysms like this one. This is a P2, P2A, P2P aneurysm. We prepare for the bypass. Unfortunately, sometimes we don't need the bypass. This is the situation, a subtemporal approach. It's not exactly a cranial base approach, but you need to master the cranial base approach we take out a bit of para-hippocampal gyri in these aneurysms, like you took a bit of gyrus rectus in the, we suffer intraop rupture, you see, very easy to control because we achieve the proximal control before, and the technique is the same. We shrink the aneurysm, we trap the aneurysm, and in this case, we were able to reconstruct the aneurysm. The technique is the same. We didn't need bypass in this time. We reconstruct the case. Unfortunately, you will see the control now. We were able to reconstruct this. Of course, very important to have neurophysiological monitoring this time, because it's impossible to know what is happening. Otherwise, you know, the PCA has a lot of perforators to the, this is a year later, you see, totally reconstructed, the artery. But there are cases like this one, 8 embolizations. These are very funny. We have to be open to techniques. This patient was embolized 8 times. And it's amazing because this was a female patient and was my mother knew this girl because they attended church in Galicia, we're from the north of Spain, together. And she was embolized 8 times in a very close hospital. And I didn't know anything about this patient. I didn't even know my mother knew this patient, but they referred the case to me without knowing anything. I don't know, 6 years later, after the 8th embolization, with a severe compression of the, you will see here, of the brainstem, and suffering, starting to suffer hemiparesia and extrapyramidal for mesencephalic compression because of the coiling. And in this case, what we did was to, this was the situation. Look at this compression because of the cleats, because of the thrombus. Of course, embolization is very good and is superior to microsurgery many times, but not in this case. What we did, again, proximal control. This is the PCOM, P1, P2. After achieving proximal control, we go to the aneurysm. With CUSA, we aspirate the aneurysm, and then a terminal suture, and the problem is solved. So sometimes we have to, this is one of the reasons why I tell you, no matter how the embolization is improving, we have to keep on working on bypass. This is another case, SCA aneurysm with a distal STA superficial cerebellar artery, and solved. If you see the literature nowadays, you see in the late years, the number of reports published on the on bypass operations significantly decreased after the approval of flow diverters for aneurysm treatment. This is a reality. This is the situation. The flow diverters are the solution for many cases. It's still very expensive, but very good. I have nothing to say about that. But whenever there is a need of flow replacement or flow augmentation, the bypass will continue to have a role in neurosurgery. This is my conclusion. Thank you very much.
Why did you not use the vein bypass? What is your conviction?
Yeah, I use the R3 more. Now things are starting to change because I'm using more vein in the last years. I will explain you why. But the main reason is why I started doing bypasses. I read all the literature of the cardiac surgeons, and I see the patency, the long-term patency with vein grafts and with internal mammary artery. What's the other point? The problem with on the other hand, most of my heroes, Robert Spetzler especially, were using vein grafts. But when I went to the barrel, he moved to the radial artery and changed my mind. Because the problem with the radial artery was the vasoconstriction sometimes. But using calcium channel blockers, the problem was solved. And with the pressure dilation technique published by Laninger-Sekar, but discovered by Kamiyama in Japan. You basically you destroy the the muscle of the, and with pathological studies, with a very good paper, they proved that there was no problem with the intima, the only important thing, the most important thing of the artery, and we started using artery. What was the problem with the artery? And maybe the reason of your question, the size is not always adequate, especially in small women. We have problems. Sometimes only because of the length, impossible to take out. You need to get 18 centimeters, more or less. And it's almost impossible sometimes with the radial artery. And now the radial artery, because of the endovascular, because we're going from the radial artery, is starting to be sacred. Please don't use the radial artery. But what happened in the last years? That the vascular surgery improved a lot how to extract the vein endoscopically, changed our life forever, because one of the reasons why we didn't use the vein was the scar they have and probably sometimes infection in the leg, especially when you went to the groin. And the second reason, we were reluctant to take out the valves. You know, when you use vein, you know, you have to put the vein in the same way, because the valves, the veins are designed to take out flow from distal to proximal. But what was the problem when I was young? The distal was smaller than the proximal, what you put in the MCA, which is quite big sometimes. But in the last years, taking out the veins with endoscopical extraction, we're using more veins. But I would say 90% of the cases, 90% of 12 cases a year, we operate on a lot of aneurysms a year, but we perform 12, 15 a year. It's not that frequent. 90% of the cases, I would say, if we perform 15 bypasses, 10 at least would be STA MCA, because with the knowledge we've gained of other of the brain circulation, of the figures of what the MCA needs, the ACA needs, the ICA needs, how to handle the perforators, in 10 out of 15 cases with STA is enough. So the vein is regaining a role in this surgery, but STA is taken out, and it's the same anywhere. Because if you see Michael Lawton with his huge series, he moved to the 3rd generation bypass, and when we need, he uses a very short graft, maybe vein, maybe artery, whatever. But again, definitely the vein is again regaining a role.
On the giant paraclinic, do you have any experience on the contralateral going for clipping? When, because we know for Goldberg, but you know there are too risky in time. But do you have any experience on contralateral?
In giant, I have a problem to go contralateral. I have I would say, quite a nice experience in contralateral paraclinic, because especially, but I would say in small. In small is definitely quite easy. To the young people, if you go from the other side, you have the optic nerve. If you dissect above the optic nerve, you go to the Japanese call the C1. You go to the bifurcation of the ICA. If you go below the nerve, you go directly to the ophthalmic segment of the SCA. And if you see the anatomy of the anterior clinoid, the distal dural ring comes from medial to lateral, from proximal to distal. So, to sum it up, you have much more room to operate coming from the other side. You seldom need, for a small aneurysm, the control to take out the anterior clinoid. What is the problem? When I use, I've been using, because I don't know why, but the incidence of multiple aneurysms in the last years here in Albania is the same. We're watching more and more patients with multiple aneurysms, and I have a small paraclinoid aneurysm, and I don't know, an MCA from the other side of carotid ICA bifurcation aneurysm. I come from the contralateral with no doubt. What is the only problem? The cervical control is much more difficult. It's feasible, but it's much more difficult because you have the patient placed like that. And the big problem, because your question was from the giant, I can check all the circumference of the wall of the aneurysm. And if you, unfortunately, you have calcium in the other side, you can tear the neck of the aneurysm without control. That's the only reason why in giant, I usually go from the same side. I go contralateral to small aneurysms, but not for giant. Because of the reason, the quality, because of course, if you try something with experience like you can succeed, but sometimes it's very unfair, neurosurgery, and there is a bit of calcium in the other side, you have a very terrible situation.
Thank you.
Thank you very much. I'm calling Dr. Mariana Ruka, talking about spinal AV dural arteriovenous fistula.
Yeah, I'm a young neurosurgeon at the University Hospital Mother Teresa. Today I'll talk about the bimodal treatment of spinal dural arteriovenous fistula. As you know,
Por favor, para
this is a rare
compartirlo, por
disease.
favor.
There are approximately 5 new cases per million, from which only around 10% of the patient come to the attention of a neurosurgeon. It is the most common vascular condition, accounting around 70% of the cases. And it's very important to recognize this disease, because if it's left untreated, it can have it can cause dysfunction of the spinal cord and mark disability of the patient. All the patient needs treatment, and the treatment consists in disconnection of the fistula, which can be done either by the surgical means or treatment by the endovascular team.
Excuse me,
The
Doc, can you
selective spinal
please share the
angiography
screen?
started in Europe in 1961 in the Larry Pazier Hospital from the radiologist René Jean under the leadership of neurosurgeon Raymond Boudard. Here is a in the May 1st, 1969 regarding the selective angiography of the spinal cord. During that time, the experience is brought back in Albania. We started the supraselective spine angiography with the endovascular treatment in 2010. With the support from Professor Emmanuel Boudard from Hospital Gariboisier, as Professor Petrella did his residency during that time in Paris, and this technique and treatment is done on a regular basis from Dr. Evgen Enescu. You can check this article regarding very detailed the history of the spinal cord lesions published in Neurosurgical Focus in 2006. A short description of the anatomy. These are the segmental arteries coming from the aorta, and you can see there is an anastomic network around the perivertebral and paravertebral vessels. This is an X-ray view. Usually we have a branch of radiculomeningeal artery which comes in contact with the radiculomedullary vein, usually at the dorsal view. As you can see here, at this point, you can see fistulas are between the level P4 and L3. The lower cervical region and the upper abdominal region is very rare. The cervical region counts for 4% of cases, and the upper cervical counts for 2% of the cases. The symptomatology is related to the venous hypertension. It's very rare to have subarachnoid hemorrhage due to the upper cervical fistula. This condition is considered an acquired condition because it's very rare in a patient younger than 30-year-old. And it's very common between the 4th and the 7th decade of the life. 80% of the patients are males, and usually it occurs on the left side. is very interesting. An article by Wang and colleagues reported that in a series of 326 patients, he reported that 80% of the patients were treated for other diseases like degenerative spine disease, inflammatory spinal cord disease, and peripheral nerve disease. And 20% of the patients already had the surgery before the diagnosis of the fistula. Usually the patient comes late at the hospital. The mean time of onset of symptoms and diagnosis is 22 months. And this, as we said earlier, is very important to recognize this condition early and to come to the attention of the medical team. And all the patients at presentation are neuropathic. There are different classifications of fistulas. The current one and the accepted is that from the special group. The first type is epidural arteriovenous fistula. The second one is intradural fistula, either congested vein on the dorsal aspect of the spinal cord or on the ventral part. Here you can see the AVN, which involves both intradurally and extradurally. And the other type is recognized AVM. The other case is a diffuse AVM, and the last one is a Crohn's AVM. Okay. This is a 60-year-old with history of spastic inferior paraparese with urinary retention. We use Aminov-Dog classification regarding the symptoms, and he was restricted and could walk with assistance, and he had urinary retention. Here you can see T2-weighted imaging of the spinal cord. In every patient that we see hyperintensity more than 40 level, this of the spinal fistula should be suspected. The gold standard is the angiography of the spinal cord. As you can see in this case, the left line, where we can see the congested vein, but at the same time we can see the Adenoid artery, which is the main feeder of the spinal cord in the thoracolumbar region, and in the upper cervical part is the arteriole Lazortes. This case is considered too risky for endovascular team, as a liquid emolic agent can obliterate the Adenoid artery and can have consequences. So it was decided to undergo surgery. As you can see on the other side, you can see the spinal nerve. On the middle side, you can see congested vein, and always, as we said earlier, we are searching for the fistula at the level of the dural sleeve. So here you can see the fistula, congested vein, which is intermingled within the bundle, within the fibers of the nerve. I will fast forward the. This is the isolation, coagulation. This is the Adenoid artery. Is always important to identify this artery when you are operating on that level. And usually this is a fine artery which has always an anterior trajectory. This is the post-op angiography where you don't see anymore the congested vein, but only the adjunctive artery and the anterior spinal artery. This is another patient, 56-year-old, which was presented paraplegic with urinary retention, and the angiography here on convexal MRI, we can suspect the fistula, but as we said earlier, the gold standard is the angiography. This is the injection of the left T5, which is in the same trunk with the T4, and here you can see the congested vein. This procedure was done with a minimal hemilaminectomy.
Yeah, I'm clicking.
Keeping the slide.
Okay, okay, you can see the dura is open and the artery. Extradurally, there are some hypertrophic vein at the suspected level, but as we said, angiography is the gold standard, but we can suspect when we see these vessels. And okay. It won't. Okay, let's go with the same with other patient. This is a 65-year-old male. He was again paraplegic with urinary retention at presentation. This is an uncommon case because it's a left L4 fistula, which is very rare. As you can see on the T2 sagittal weighted images, you can see some hyperintensity of the level of the cones. This on the lateral plane, you can see congested veins. And here we have a 3D angiography with the vessels around the cones and this patient underwent surgery to L4 laminectomy. Here you can see this calvaecna, the nerves, and between the nerves there is a hypertrophic vessel which is isolated and disconnected. This is a 37-year-old male patient who was operated recently with a 3-month history. He could walk only assisted, but 1 week before admission, he deteriorated and he did this MRI which showed hypertensity in multiple bellows, and this is the injection of the left tip. It's an overview where you can see the congested vein and the Adamkiewicz artery at the same level. So the same technique, the spinal nerve is inspected carefully, and the Adamkiewicz artery is identified. Computers. These are the congested veins, and this is a suspected fistula. So this vein is isolated and coagulated. You can appreciate the decongestion of the vein immediately. And this is Adamkiewicz artery. This is for surgical treatment. We also perform endovascular treatment. This is a 48-year-old male presented with walking difficulty. He could walk only assisted and had urinary retention and presentation. This is the T2 weighted images, and on the angiogram, you can see the fistula and congested vein. This is to verify the Adamkiewicz artery. So you should be sure that the level of Adamkiewicz is not the same with the level of fistula. And this is the treatment. And that's the image. You can see there is no more any early venous filling. This is another patient with a depth P6 fistula. On this side, you can see the catheter and the micro catheter system with a tip at the level of the shunt. And you can see here the embolic agent and total obliteration of fistula. The outcome is better if the patient comes earlier. Usually, the best outcome is within 6 months from the onset of the symptoms. And the imaging findings are not useful for prognostication. The patient age and the neurological status and diagnosis have no influence on the long-term outcome. It's better if the patient is diagnosed early, and the The sphincter dysfunctions, like mutilation, defecation, or sexual functions, have a poor prognosis. Usually they don't improve, and the best outcome is for the thoracic lower level fistulas. Thank you. Yes.
Very presentation. Yeah, just a trick. When one of the more difficult things is you know where is the fistula once you are going to operate them, because you have to count all the levels, and it's not very easy. You don't do a very big laminectomy and you want to go straight forward. It's sometimes you last a long time to know where it is. So I asked my endovascular colleagues to say, okay, if you are not going to embolize it, please put a coil or something else there in order to know where it is. And I go it and I save a lot of time in OR thinking, okay, it's here. So it's because your procedures are better.
Yes.
I'm using a case of recanalization after endovascular.
Endovascular treatment has a success rate around 80%, and the surgical treatment has a success rate around 98% of the cases. With the improvement of the technology, with the new embolic agents, diaconics, the outcome are better, but we should be, the endovascular team should be very careful when treating this type of fistulas, because if they recanalizate, the patient shouldn't lose time to go to the surgery.
That's correct. We say that every time we have the hour radiologist to say, here it is, just a neuro at the level in the scar, and right away. And the other question that is that we have a small experience with endovascular. So it's 1 or 2 per year. But till now, for more than 12 or 14 years, they didn't have recanalization.
I made that question because for me it's important. You know, this is type 1, the VM, spinal, type 1A, only one fistula,
and multiple
several
figures.
It's, for me, my humble opinion, there is no indication for A1, A, for endovascular. But for AB, we have several figures, several fistulas. I think endovascular can provide with a very reliable way of taking out cutting the fistula and much less invasive. But it's very difficult to justify an endovascular approach in a single fistula because you prove that even with an appendectomy you are able to do. It's very difficult to get a reason
we have our treatment strategy is that we try tentative embolization if there are no contraindications regarding the endovascular treatment. And for example, if we have a Dankovich artery at the same level, that is a contraindication.
But saying the truth, they have been connected with the design bed. So they sometimes say that most likely surgery. That's
Thank you.
So about the treatment of posterior fossa, posterior fossa approach in the treatment of
sus nosotros en España.
Good afternoon. My name is Ángel Ortejales, working in Granada. I'm very pleased to be here. Thank you for inviting me to this wonderful meeting and for your hospitality. And the topic is the posterior fossa approach for vestibular schwannomas. As my colleagues, I like to talk about history before my lecture. And the vestibular schwannomas were described as early in 1777. But until 19th century, it was a relatively unknown tumor until the 19th century. At the end of this century, some attempts were done to try to remove CP-angled tumors, usually with a disaster. It was usually a disaster. Every patient died. And the first surgeon who did a successfully removal of a CP-angled tumor was Sir Charles Valence in 1894. It was a woman, she survived, but according to Harvey Cushing, it was not a vestibular schwannoma, it was a meningioma. The first surgeon who did a successfully removal of a vestibular schwannoma was Thomas Annandale in 1895. The modern era of the neurosurgery started with Cushing, and Cushing operated on his first case in 1906. It was at that time, usually the diagnosis was very late, big tumors. The patient who he operated on was blind because several intracalcium hypertension, bedridden, and he operated on in a sitting position. His assistant was supporting the head meanwhile he was doing the operation, and the patient died 3 days after the surgery. He operated on a second case 3 months later. He did it in a prone position. He did a broad exposure of the posterior fossa, and this patient survived. From Cushing, neurosurgeons took some learnings, like operating on sitting position, because this position enables a clean surgical field, the use of ventricular drainage to manage the intracranial hypertension in case of hydrocephalus, a broad approach taking out both occipital bones, arc of Atlas, and foramen magnum, and Cushing recommended to do a partial and not a total resection. In 1917, he published a series of 30 cases with 15% of a mortality. At that time, the mortality used to be between 60 and 80%. Another giant of neurosurgery was Dandy, disciple of Cushing, and he operated his first two patients in 1915. These two patients died 12 hours after the surgery. Soon after, he operated another 3 patients, and 2 of them died in the next 48 hours. But he went on doing this kind of surgeries. It's incredible. He went on. And in 1917, he operated a patient, a woman, following the advices of Cushing. He did a partial resection. The patient went well, but 2 months later, she deteriorated, and he reoperated the patient, and he performed a total resection. Since then, he begged for total resection instead of the partial resection recommended by Cushing. And in 1925, he published his series of 23 patients with higher mortality, 30%, but with greater resection than Cushing series. The learning from Dandy were smaller approaches. He described the retoxic mode approach, and he begged for total resection instead of partial resection. We have to mention also of this Oliver Krohn, the Swedish neurosurgeon, that in 1967 he published more than 300 cases with a mortality of around 90%. The modern era, in the 60s, start the otoneurosurgical stage, and the main representative of this stage was William House. William House was an otorhinolaryngologist, and he described the subtemporal approach and the transsyllabic approach.
he started to do it combined with neurosurgeons, combining translabyrinth with suboccipital approaches, initially with Doyle, after with Hesselbender, but finally he abandoned the suboccipital approach and he started to do it only translabyrinth. And he published in 1978 a wonderful series of 200 cases with 7% of mortality and 86% of total resection, with facial nerve preservation very high, 72% of total facial nerve preservation and 23% of partial facial nerve preservation. The main contribution to surgery of this surgeon was the use of microscope in surgery. The responsible of using the microscope in neurosurgery was, of course, García Sargil in the 70s. Sorry, and at that time, a lot of auto-neurosurgical teams were made, and at that time the controversy was between the retrosigmoid versus middle fossa approach. Since the 80s, the microsurgery develops and the neurophysiological monitoring enters the scene, and since then and nowadays we are talking about not mortality but also facial nerve and hearing preservation. And where are we now? Now, usually the vestibular sonoma are diagnosed very early because with the spread of MRI, most of the tumors are small and medium-sized tumors, and we have to do a quality of life surgery. We have to try to preserve facial nerve function and also hearing. The surgery of the CP angle is a very demanding surgery because in a very narrow space between the brainstem and the petrous bone, we can find a lot of vital structures, a lot of cranial nerves between the 4th and the 12th nerves, cranial nerves, and very important arteries like ICA, PICA, vertebral artery, or supracerebral artery. Also, the facial nerve is a very complex structure made up of 4 nerves. The facial nerve is located in the anterior superior part of this complex, and the vestibular and the sonoma arise in front of the vestibular part of this facial nerve. So usually the facial nerve is passed in a superior and anterior direction. So different approaches has been described to treat surgically these tumors, and each of one has his pros and cons. The translabyrinth approach, described as we have told by Wienhouse, provide an excellent anterior and superior exposure of the tumor. It has a very low rate of CSF leaks. It's easier to maintain the facial nerve function, and it lets also to put a cochlear implant if it's necessary. The main problems of this approach is that the inferior part of the tumor can be limited by the jugular valve. If the tumor has a biggest posterior fossa extension, is not a good approach, and of course the loss of hearing is always you lose the hearing. The middle fossa approach is an excellent approach for intracanalical tumors. With this approach, the hearing and the facial nerve function used to be preserved, and the rate of CSF leaks are also low. The drawbacks is that if the tumors extend in the cerebropontine angle, is not a good approach, and sometimes we can have problems with the temporal lobe or the vein of Lavey because of the protraction needed to access the floor and the roof of the petrous bone. Before doing a surgery, a retrosigmoid approach, we have to take into account some preoperative consideration. We need an audiometry to plan hearing preservation. We should have an angio MRI in venous phase, to evaluate the patency of the sinus, especially if we are thinking about to do an extended retrosigmoid approach. We need a skull-based CT scan to evaluate the air cells in the petrous bone. And if we are thinking to do it in a sitting position, an echocardio is necessary to rule out if there is a foramen oval to avoid brain stroke in case of embolus. Regarding the position, to do a retrosigmoid approach, we can choose between the semi-sitting position. This is the classical position. The main advantage of this position is we have a clean surgical field because all the blood comes out from the surgical field, but it has some disadvantage like the risk of air embolism. Sometimes it's not easy to manage the blood pressure with the patient in a sitting position. It's uncomfortable for the surgeon. We have to be operating with your arms elevated, especially if you are short like me. It's not easy with forearms. And there is a risk of pneumocephalus and several, and you need also to retract the cerebellum to access the CPA angle. The lateral in the cubitus or the park bench position is more comfortable for surgeon. There are less risk of postoperative pneumocephalus or air embolism, and sometimes you don't need to retract the cerebellum. The problem with this position is sometimes the shoulder could interfere the surgeon to work, and it's not easy to do it in obese patients. There is a variant of this position is with the patient in supine and the hair rotated. You can do it in young patients, and especially in thin and young patients. And but it has two main drawbacks: is you can compress the contralateral jugular vein, and the angle of approach is worse than in the other position. In this systematic review about the complications related to the position, they didn't find any difference in complication between the sitting and lateral position. It's mandatory to do the surgery with neurophysiological continuous monitoring. You have to monitor all the lower cranial nerves, trigeminal nerves, oculomotor nerves, the facial nerves. You need to monitor the auditory evoked potentials, and also motor and sensory and somatosensory evoked potentials. If we are going to do the surgery in sitting position, it's also necessary to have an echo Doppler, a cardiac echo Doppler, to detect air embolism, and a catheter in the right atrium to extract the air if it happens. Neuronavigation is not mandatory, but is also helpful. I prefer personally the lateral decubitus. We usually put the contralateral arm out of the table. We put a pillow under the contralateral armpit to elevate the thorax, and a slight inverse in the lemur to put the head over the heart to reduce the venous pressure. We flex the head and tilt the vertex toward the ground, and we pull the shoulder toward the body, taking into account that not to stretch to mask the brachial plexus. The incision, is curved around the mastoid, and the burr hole is placed in the asterium. The asterium sometimes is not easy to find in all the patients, so in these cases, neuronavigation will help us to place the burr hole in the correct place. And we used to do craniectomy in older patients because dura used to be attached to the bone, and in these cases is the risk of venous sinus damage is with the craniotomy is high. You know? We have to take into account that the vertebral artery is in the lower part of the incision. We have to take care of it, and we can also drill the bone over the sigmoid and transverse sinus in order to gain angle of approach. This is the extended retrosigmoid approach. And in these cases, as I mentioned before, it's better to know how is the sinus, because if we have some problems in the contralateral sinus, it can be risky to put to deal with this sinus in the same side. The dura is open in a cross fashion. We retract the dura towards the sigmoid and transverse sinus, and to deal with the posterior fossa is a small place, and we have a tumor that it can be very tight. We can put a spinal drainage. We cannot do the spinal drainage until the dura is open because the risk of tonsillar ignition. But there is another way to deal with this. It's not working. We can elevate the cerebellum and get access to the basal cisterns, open the basal cistern, and release CSF from the basal system. With this maneuver, taking out CSF, the cerebellum relax, and most of the time we don't need any retractors to deal with the cerebellum. Once we visualize the tumors, we release it from the surrounding cerebroid layers. First, what we have to do is to stimulate the tumor in order to identify if the facial nerve is displaced posteriorly. It's not common, but sometimes it happens. But it's very, very important to know where is the facial nerve. We have to maintain the adenoid plane to protect the brain stem and also the cranial nerves. We have to identify in the inferior part of the tumor the lower cranial nerves and protect them, and in the superior part of the tumor the trigeminal nerve and the superior petrosal vein. We have to identify also the vascular structure, ICA and PICA, and we can also open the internal meatus in order to identify the intracanalicular extension of the tumor. In this short video, operating in a sitting position, we are now releasing the CSF from the basal system in order to relax the cerebellum. Now we are coagulating the capsule. We usually do an internal debulking, usually with ultrasonic aspirator. We combine the debulking with resection of the capsule. This is a small tumor. In the upper part, you can see the trigeminal nerve. And in the inferior part, we have to identify the lower cranial nerve and dissect them from the tumor. Here you can see all the lower cranial nerves. And after drilling the internal auditory canal, we can see in the bottom the facial nerve and the tumor are dissecting away from this facial nerve. Closure is very important in this surgery. If we don't do a nice closure, we can have one of the main problems is the CSF leaks, and it can be a disaster, even if you have done a marvelous surgery. Dural shooter usually is very difficult to do a watertight closure. Some years we discovered TouchSeal to close to complete the closure of the dura, and since then our CSF leaks have dropped dramatically. We can use fat also to ensure the closure. We have to identify and close possible petrous bone cells to avoid CSF fistula through the middle ear. We used to replace the vein or the bone, sorry, or if we don't have the bone, to put a titanium mesh, and we close in a multi-layer fashion. And there is a technique we use is to release the head tilt. When you release the head tilt, when you are closing, the muscle relaxes and the closure is easier. The complications of this surgery can be very, very, very important. We can get cerebral injury due to the retraction, venous-sinus injury during the surgery, or venous-sinus thrombosis after the surgery. We can have cranial nerve deficit from trigeminal to lower cranial nerves. The lower cranial nerves deficit are devastating for the patient. Brainstem injuries, vascular injuries. The CSF leaks, as we have told, can be very high in some serious. Meningitis, usually secondary to these CSF leaks. And another minor complication for us, but not for the patient sometimes, headaches and tinnitus. In this review about the complication related to the approach, we can see that the complications are not only related to the approach, but mainly to the size of the tumor. In this review, the hearing preservation is very high when we operate intracanalicular tumors via middle fossa, and it was very poor in big tumors operated on retrosigmoid approach. The facial nerve preservation is very high when the tumor is small, and we do it via middle fossa. And in this review, the highest figures of facial nerve problems were with translated approach in big tumors. CSF leaks are higher in retrosigmoid approach. In this series, mortality was higher in translated approach, and another problems with another cranial nerves were higher in retrosigmoid approach. We have to pursue a total resection. This is a question because total resection is related with facial nerve problems. In this review of more than 1,300 patients, those patients who achieve a complete resection have facial nerves problems in high percentage of the cases. And in this consensus of the Ian's skull-based section, they conclude that the main goal of management of large vestibular schwannomas should focus on maintaining improving quality of life, making every attempt of facial cochlear nerve functional preservation while we are ensuring optimal oncological control. This is why radiosurgery came here to change everything. In this classic paper of Pollock, he compared two series of patients, 46 treated with gamma knife radiosurgery and 36 treated by surgery, and he evaluated the function of the 7 and 8 nerve, the working status and quality of life. Well, the result of the paper was that the quality of life was better in radiosurgery at 3, 12 months and last follow-up, and the complication was higher in the surgical group, and not also higher, but also more severe, with a tumor control very similar, 96% against 100%. So nowadays, this is more or less the algorithm of treatment of every department of surgery. Tumors less than 3 centimeters used to go to radiosurgery, and only the tumors over this size came for surgery. In my opinion, what kind of tumors are suitable for surgery? Cystic tumor, in my opinion, have to be operated on because surgery is very easy, and you with an easy surgery you can reduce the volume of radiation, making the results of the radiosurgery better. Of course, big tumor like this cannot be managed with radiosurgery. You have to remove a tumor to improve brainstem compression and so on. Another indication for surgery could be symptomatic tumors, for example, tumors that are causing a trigeminal neuralgia, and in case of fail of radiosurgery. What is, in my opinion, the surgical strategy nowadays? We are trying to do a quality of life surgery. I think the surgical strategy nowadays should be a subtotal resection followed by radiosurgery. With a subtotal resection, it's very easy to maintain the function of facial nerve, and usually the patient have a very good postoperative. But we have to take in mind that we have to, the goal of the surgery is to reduce the volume of radiation. So we should try to get this kind of result after surgery and not this kind of result after surgery, because the volume in the first case, in the upper case, is the same like the original tumor. This is a case of a vestibular sonoma treated surgically with a small remnant. We did it after radiosurgery. And sometimes if you get a very good resection after surgery, you can wait and see. Sometimes it's not necessary to do necessary radiosurgery after surgery. In this case, we did a very good resection, and the follow-up 5 years after the surgery demonstrate that the tumor is the same. So we didn't do anything else. For finishing, I have to say that I think the retrosigmoid approach is a very good approach for big and small tumors. Unfortunately, now you usually face with big tumors in the CP angle. We try to do surgery to preserve facial nerve function, and if we can, also hearing. It's not an easy surgery. It must be done by expertise neurosurgeon. We have to do a careful preparatory planning, and of course, intraoperative neuromonitoring is mandatory. And in my opinion, now the best strategy for these tumors is because we usually face with this kind of big tumors, is a subtotal resection followed by radiosurgery. And as my colleagues have told, we invite you to our World Congress of Neurosurgery that will be celebrated in September 2025 in Madrid. Thank you very much.
Thank you very much for this wonderful presentation. I have a question. What do you think about surgery post-radiosurgery? Do you think that is more difficult, more easy? We can do it because there are many people that asking this from the neurosurgeon also.
No, in my opinion, it's not more difficult. We have operated on some cases after radiosurgery. I think it's not more difficult, and there are papers that demonstrate that there is no big difference between the tumors treated previously with radiosurgery.
Thank you.
Thank you for your presentation. Just we use the Doppler in order to know where is the sinus. Very easy, very fast, and you can know exactly where is the position where you use, but the higher is the benefit to me, the better is the. And you also with the surgery, the reason has been treated with therapy of more than 3 or 4 sessions, in which there are more fronts to operate on. We have done radiosurgery. I agree that Thank you for your very, very clear message that you said. One opinion, probably not every here, I love that. Here's a paper in GNS by a Dutch group on large phenomenon that they adapted wait and watch. It was swallowed with difficulty by the boards of GNS, but they published that. Do you have any experience of people that have large that have been for 10 years after your consultation?
If in large schwannomas, wait and see, depends on the age, it depends on the situation of the patient, but I don't think it's the natural history of the vestibular schwannomas is
imbalance, great coordination after, but in their paper they show that if it is only with except when they are with coordination problems, but if they are only with the hearing preservation, they say no.
Could be an option.
very contradictory opinion.
Well, I think that there is a study from North American otolaryngology that speak about 5 years after the diagnosis of neurinoma, they have no more there are no more grow-ups. So that if you can see in the first 5 years, they can grow up, but after the 5 years, they stop to grow up. Maybe there is some kind of philosophy that not of the
There are a lot of papers about the natural history of schwannomas. Some of the schwannomas also regrets, but it's difficult to say.
Question. Go to the small ones. I know that the Shiva was so and that's one can very fast probably quite easy. But the intercanalicular ones, there's a minor hearing defect. What would be the indication for surgery? You will follow them up, of course, but when would you turn the time towards surgery?
If we find an intracanalicular tumors, we usually do a follow-up, especially if the patient have a preservation of hearing. We do audiometry and we do a MRI. And if there is no change, we don't do anything. If there is any change, this patient usually go to radiosurgery. And you give the patient the choice to open the head and radiosurgery. They always choose the radiosurgery.
For the audience, that is the need problem that sometimes is not solved, but surgery neither by the surgery. So one of the things to type of surgery of treatment the patient has tinnitus,
There are some papers about the approach and tinnitus. It looks like the middle fossa approach less have chance of postoperative tinnitus than other approaches. But even otolaryngologists they don't know how to manage this problem. It can be a very big problem for the patient.
I think that in the first couple of years, the patient has been reduced, but I treat some patients with flexibility and they became they are not so they became better with flexibility. I think that I treat with flexibility sometimes.
Which the problem is not the post-op tinnitus.
It's a pre-op.
This is the pre-op tinnitus. This is the problem. Tinnitus is a pain event. Sometimes it's almost impossible. They tried in several papers using that cortical stimulation of the resistance. Sometimes it's impossible. This can be linked to the question of Professor Mentor, is that you can watch and see even big tumors, but not big tumors with tinnitus or with vestibular symptoms, because so far we have few reports, but they are the tumors more likely to grow in the future. It's something crazy, but a guy with tinnitus or with vestibular complaints, there are several papers on that. These are tumors are more prone to grow in the future. If you have a patient only with especially if the patient is dead, already dead, here, it's very difficult to justify the surgery only because of that, because you are not going to improve. You may worse the vision, but not improve that. And if you have a patient with tinnitus, please. Even if you are patient, but the problem with this, especially with big tumors, you can be very conservative and you are partial debulking of the tumor, and then you can treat it with radiosurgery if you want. But if the patient has the vestibular or tinnitus, we need to operate on send to radiosurgery. Sometimes it's difficult to combine a patient to the literature to operate in a very small tumor, and they prefer radiosurgery. If they are patient, they even improve in the future. They stand
also, the tinnitus also may have some incidence on the fluid of the CSF turbulence, maybe a blockade, and the system gets a path which makes turbulence, and this vibration causes impulse. So that's why sometimes we compress them, and they get better. So this is gets better.
Our limit in surgery is the facial nerve. We resect tumor until we find the facial nerve. We find something that, because in big tumor, you know, the facial nerve is spread and it's very difficult to identify. And
Wait to do a surgery after operation? Or it was
no, stay ahead. Depends. We have cases we don't do radiosurgery if the resection has been very good. Usually 3-4 months after 3-6 months.
Don't wait for the residue to regrow for offering radiosurgery.
Depends on the residual tumor. If it's big residual tumor, of course we do it directly. If the residual tumor is very small, we can wait and see. Yep.
Thank you very much. Dr. Kita Salabana is going to talk about the treatment of spinal tumors.
Well, thank you very much. I want now to make a big pass to tell thank you to Mimi Pavelli. Mimi Pavelli is a member of the Albanian Parliament and the president of the Foreign Committee of the Albanian Parliament. Thank you very much for coming and to be with us. Well, I'm speaking for something that is important and different, that is the combined treatment of the spine lesion surgery and the radiosurgery. You know that I begin with a very important expression of Henry Marsh. Henry Marsh is a big friend of Albanian department, that he told the most difficult of my job is not to make surgery. The most complicated is to decide to make it or not, and to live with the consequence. And this is a very important concept, because from this concept, we have to decide which kind of surgery we have to do. I begin to demonstrate your case. There is a young girl, 48 years old, with a breast cancer diagnosis in 2011. When she came to my consulting room with MRI, you can see here there is a big lesion in the D8, in the thoracic part of the spine. And there is another case. There is a patient. There is a patient of Dr. Petrella. I think that there is a patient with 61 years old, with a lesion in the junction, bulbomedular junction, with very progressive tetraparesia. There is another case that we can resolve this case later, but in the beginning, I want to demonstrate you this case to understand why I take the decision that I took. This is another young girl with 38 years old woman. She came to my consult with a very severe tetraparesia. She was going to one hospital, another hospital. They was thinking that there is something of the myelopathy, cervical myelopathy, and something discal cervical hernia, but was not so clear. Well, if we're speaking about the spinal lesion, we can see that the most frequently there are metastases, later are neurinoma, therefore meningioma, and ependymomas. Now, every year in the United States, we have 118,000 new cases with spine metastases, and from them, 20,000 are spine lesion with medular compression. And it is very important statistically that many of these lesions are intramedullary. There is very important pathology. Well, we think that the most frequent cancer that produce metastases in the spine are the cancer of breast, therefore the cancer of lung, and the cancer of prostate that is normally in the men's. And the type of the cancer are renal, thyroid carcinoma, sarcoma, lymphoma, and melanoma. In pediatric age, we have normally sarcoma and medulloblastoma. The most important pathology of the metastases are the medullary compression. The majority of the cancer, the medullary compression is in the dorsal spine. The localization of the metastases, therefore, are in the lumbar spine, and therefore are in the cervical spine, as I told you, that are very important, that are localized in the intramedullary. There is a very big, very important pathology. We have to change the concept. We are speaking how the metastases are going to the spine. It means that it's a different concept from the brain. In the spine, there is a complexity. There are some other elements that are called osteoclasts and osteoblasts, and they make possible the implantation of the metastasis in the bone. You know that the philosophy of the implantation of the metastasis in the brain is that through the vascular way. But in this case, there are more different elements that make possible the implantation of these metastases in the bone. Well, we are speaking about the treatment. We have different options. There are medical, surgery, radiotherapy, combined treatment, and radiosurgery. It means those are our options. How can we resolve the problem of the patient? But to take this decision is not because we decide to make some kind of decision. No, it's based on very determined criteria. The first one are SINS criteria. The second is Bliski classification, Tomita classification, and NOMS criteria. It means that everything in medicine has to be based in some very clear concept. Well, if we're speaking about SINS classification, we're speaking about the motility of the stability of the spine. If the spine is not stable, we have to make surgery to fix the spine. And those are the criteria. We have stable in the classification of from 0 to 6, are potential unstable from 7 to 12, and are unstable from 30 to 8 points. In the third group, is sure that we can make surgery. The first option of treatment is surgery. Later we can discuss in the second group if to make surgery or if we have to make combined treatment. But in the third group, every people have to go to the surgery. Tomita classification also very important to introduce us in the concept of the treatment, because he's speaking about that how is the distribution of the tumor and which part of the bone is occupied from the tumor. Well, we're speaking about the NOMS criteria. NOMS criteria are very important because we are speaking about the metastasis, that the metastases of the spine are not a separate pathology. We are speaking about a systemic pathology, because if we have a metastasis in the spine, we have to think that we have a primary tumor, and we can treat this pathology thinking that it's a systemic disease with a local localization, and which is the metastasis. For this reason, the NOMS criteria are very important because are neurological, oncology, mechanical stability, that's included with SINS criteria, and systemic disease. If we're clear, we can classify it as NOMS classification, NOMS criteria, we can make radiotherapy, systemic treatment, and surgery. Well, in 2005 in Lancet, Patchell published this big paper, and it was a very important phase 3 paper about the value of surgery. It means that he demonstrated that the surgery was more efficacious than the radiotherapy. And you can see here in the result of Patchell that the people that make surgery, the people in surgery group, the survival is 126 days. And the people that did not make surgery was only 100, the survival, the medium of the survival is 100 days. This made that every people was thinking about the surgery. But in 2005, when Patcher published this paper, very important in Lancet, we have not the new technology to make radiosurgery in the spine. And you can see here that we changed the idea of the treatment. Well, you ask more or less what non-sclerotic, speaking about medullary compression, neuropathy, radiculopathy, histology of the tumor is very important, hormonal and chemotherapy response, radiosensitivity, mechanical instability, and systemic disease. Those are what Mark Blisky demonstrated are important to make the decision of the treatment. But the question is that every patient can be operated. Did we have complication in the surgery of this patient? Of course we have. And we have to think more, we have to have an open mind when we decide to treat this kind of a patient. Is the surgery the first option? Well, until now, the most important problem was the spinal cord radiation toxicity. This was a big obstacle in the treatment because in the radiotherapy of the spine, in the radiotherapy, I'm not speaking about radiosurgery, for this is make the difference in the radiotherapy of the spine was very important, the toxicity that producing radiation of the spine. What's happening with spinal radiosurgery? We transfer all our experience in the brain radiosurgery, and we are going forward to make something different, that is a spine radiosurgery, in the same way that we treat the patient radiosurgery of the brain. We have the development of the technology that permit us to make radiosurgery. You can see here, we begin from cobalt therapy, we are going to LINAC, we are going to gamma knife, we are going to proton therapy, and now we have something, a new machine that is top. You have this a very, very, very important machine that is the best in the market to make radiosurgery. Well, when we introduce this concept of radiosurgery, we change the paradigms. This is very important because in the last year, in the last 10 years, we are not speaking about surgery. We are speaking about the combined treatment, surgery, radiosurgery, radiotherapy, and this is the NORMS framework. You understand which is the framework. How can we treat the patient? We see the flow of the treatment of the patient. And for the first time, we are speaking not only about the stabilization, but we are speaking about the radiosurgery and the new concept. We can see later the separation surgery. We can see later what is the separation surgery. There is another phase 3 study published in 2017 in the Lancet Oncology that introducing every year, we are introducing new concept. The surgery is not the best option. We can see we can make different treatment for different patients and different situations. Which are the indications for spinal surgery? We can make in the reticular tumor after surgery, recurrent tumor, multipleization, unfavorable localization, and high risk for open surgery. There are many patients that cannot be operated for different reasons, because there is some cardiac pathology, there is some diabetic pathologies, mean that they cannot be operated. In this situation, we have to think about something else. The radiosurgery of the spine is some kind different from the radiosurgery of the brain, is mean because we have different indication, different technology, different clinical result, different dose limitation, which is very important, and different organs at risk. Well, when I decided to make radiosurgery of the spine, I am very carefully because of the toxicity. I base all my criteria in standard university criteria of treatment of the spine to preserve the functionality of the medulla. Well, there is evidence support. It's not so much because it's a new concept of treatment. If we're speaking about the surgery of acoustic neuronoma that Professor Okahara told us before, there's a big experience, but we're speaking about the spine. We have 10 years of experience. 10 years experience in medicine is a short time of experience, but we have something that we're speaking about, a new concept. Combine surgery and radiosurgery. Does it work? Does this strategy work? I will demonstrate you that is very interesting strategy of treatment of this patient. We have some paper about the treatment of spine metastasis. We told that is the first pathology, and in this paper we demonstrate that the combined treatment, surgery and radiosurgery, is very important. And this is the last study, and very new one, that we call Canadian schema. That is a phase 2, phase 3 study. It's very important. If we have phase 2 and phase 3 studies, mean that this establish the policy of the treatment. With this study, we can decide how to do, because we have a support. This is very important, because the phase 2 and phase 3 study make us to be sure in what we are doing. Well, this is combined treatment, surgery and radiosurgery. You can see here that the other concept is the separation surgery. Which is a separation surgery? What does it mean, this concept? We can, I will explain you that the concept of the separation surgery is to separate the tumor from the medulla, from the spine medulla, to take out the compression, and to make radiosurgery after. Well, until now, many people, for example, Dr. Lafuente is a big specialist in the spine tumors. He make a corporectomy maybe sometimes before. But now we can see that if we make corporectomy, if we take out all the bone and we make, and we put the element of support, it's not enough. Because we have to irradiate. We have to irradiate in the same place, because we have a tumoral cell there. For this reason, maybe we change this concept. We are going out from this concept, because we use in radiosurgery two very important concepts that are abscopal effect. There is very interesting effect that we can irradiate one part and we have a result in the other part. Yes, it is true, Dr. Lay. And bystander effect. There is another very important effect that is the effect of radiotherapy. Which are the bystander and abscopal effect? Are immunologic effect. It's very important, because we have to hear more and more about the immunological effect of the radiotherapy. What does it mean, this? That we can irradiate the metastasis in the lung. Maybe the other metastases that are in the spine can be disappear. This is the immunologic effect of the radiotherapy and the immunologic effect of the radiosurgery. This is the first publication about the radiosurgery of spine. My friend Moashevich do it about 287 lesions. We collaborate a lot with Moashevich, a big neurosurgeon and radiotherapist. He have both specialization, neurosurgery and radiotherapy. I have my own share. I have 52 patients treated with a combined treatment, and with a big follow-up, 42-month follow-up, and with separation surgery in 38 patients. The majority of the patients you can see here are malignant tumor, and the legs are benign tumor. And the localization are in vertebra, intramedular and extramedular, and intramedular tumor. I treated 7 patients with intramedular tumor that are very, very, very important. This is our very interesting case. We gained the third frame of the best international publication in the world about this intramedular metastasis. This patient, I treated this patient with 5 brain metastases. Later, she came to me with this intramedullary metastasis. We discussed to make surgery, but the patient was intact in a neurological point of view, and I decided to make radiosurgery. It was my first patient that I make intramedullary radiosurgery, and we decided to make single dose. It was very important. We do 40 grade single dose in May 2012. You can see the MRI in October 2012. It disappeared, just disappeared. We can see here in May 2031, year later, there is no tumor. You can see in December, we think that there was a tumor. That was the reference of a tumor, but it was not true. The patient was quite intact in neurological point of view. And the last MRI, 2 years and a half after the radio surgery, we have a cyst there without neurological deficit, and the patient died 3 years, but without from the dispersion of the pathology in the body, not from the brain metastasis, not from the intramedullary metastasis. She called me, I think that 2 or 3 days before she died, she called me to the hospital and she told me, you know, you can see I'm not dying from the brain metastasis, I'm from the intramedullary metastasis, I'm dying from the lung dispersion of the tumor. When we published this case, and this case was the 3rd international premium for the best publication in this year. This is another case with intradural metastasis. You can see here, we decide to make radiosurgery with very good result on the patient and the tumor disappear. Now I come back to our cases, but I said 3 cases that I explained to you. This is the first case. You can see here the big tumor, the big compression of the tumor, and I decided to make the separation surgery. I make surgery, I take out all the tumor because the spine was unstable, but related with the Syns criteria. You can see here, I make a posterior arthrodescent dispersion. You can see that the medulla is clear, there is no tumor there. This is the surgery, and this is the MRI after surgery. You can see there is no tumor, everything is free. To stop here, no, I have to treat the metastasis. When I decided to make radiosurgery, you can see here the radiosurgery of the patient, and she was, all the time that she lived, was without neurological deficit. Now, the case that Dr. Pezzella operated, he made a biopsy, was very, very interesting case because nobody was a PET scan, nobody was thinking what it is. And he made biopsy, and the biopsy was a melanoma. And we spoke together, and Dr. Pezzella decided to bring it to me and to make radiosurgery. Was a very good decision. I make radiosurgery. This is the major surgery. And the patient actually, I have not the MRI, but I've seen Monday the MRI, and the tumor is half, was 40 millimeter, and now is 7 millimeter on the patient. Improve all the movement on the right side. That was a pulse. It was very interesting, and we decided to make radiosurgery with a good result. This is the other case that I make surgery in this case. It means that I make a posterior approach to this big meningioma. Was very big meningioma. You can see that the medulla was almost disappeared. I make surgery. This is the MRI after the surgery. You can see here I am taking out all the tumor. I remove the medulla in the cervical. Was very difficult surgery with a big control of the breathing, and because we are at Jackson C1 and C2 was very difficult surgery. I make a posterior approach. I take out all the tumor, and you can see now this is the tumor. The medulla is in this position. On this one was medulla. This is everything was tumor. I take out. There is the rest of the tumor. The problem is that what to do in this case, to make immediately radiosurgery or to wait. I think that because we are speaking about the meningioma, I decided to wait to see what's happened because the patient improved the neurological situation. But 1 year later, you can see here that the tumor became bigger. And in this situation, I decided to make radiosurgery because the tumor became bigger. You can see here the radiosurgery, and the patient was stable in neurological point of view. This is another case of neurinoma. This is D1 neurinoma. We make an open surgery. We make a transthoracal surgery with a thoracic surgeon. We take out the bigger part of the tumor, but it was impossible to take out all the tumor, and we decided to make radiosurgery later. This is another very interesting case. It's an intramedullary ependymoma. The patient was tetraplegic. Was very important tetraplegic where she came to my hospital. I decided to make surgery because I was not clear which kind of diagnosis was. You can see here. I take out all the tumor. You can see here with the posterior linea media approach. I take out all the tumor, and you can see the MRI here. There is no tumor. The question was the ependymoma, grade 2 ependymoma. I did not decide to make surgery because in the grade 2 ependymoma, it's not necessary to make a surgery immediately. We have to wait and if we have a tumor growth, we can make the surgery. This is a different case of ependymoma that I make surgery. I take out all the tumor, but in 1 year, there was a recurrence you can see here, and I decide to make radio surgery. And 1 year follow-up after the radio surgery, you can see that the tumor had disappeared. It means that I show these two kinds of meningioma to demonstrate that not everything has to make radio surgery. No, we have to have a criteria to do it. We can make surgery if we can take out all the tumor. If the ependymoma grade 1, we resolve the problem of the patient. After, if the tumor becomes to grow up or we have recurrency, we have to make radio surgery. The big problem of the radio surgery of the medulla is the radio-induced injury. It means that this is a big problem because the medulla is very sensitive of irradiation. But if we are clear what to do, we have a clear of criteria, and with the appropriate technology. It's very important. It's very important the technology. We cannot treat it good or well a spine tumor with all the machines that are in the market. We have to have very specialized market technology to do it. And I think that the best, in my point of view, the CyberKnife, and later you can see in the part of neck and head, the sub, but the CyberKnife is a selected machine to make the surgery of the spine tumor. Well, I come back to the result of my patient, where the 90% in 3-year follow-up control of malignant tumor, we have 100% control of the tumor in 5 years, and we have no grade 3 toxicity in 100% of the patient. Maybe the neurosurgeon don't understand it, but we're speaking of grade 3 toxicity, that if you have to use medication to control the toxicity. And the conclusion are the strategy of combining with less aggressive surgical decompression roll-up to make radio surgery later. I think that we have to think about the combined treatment of spine lesion, and we have to treat about the concept of separation surgery. Are very important. A new concept we have to apply every day in our hospital. And we are speaking about intramedullary hematitis. In my opinion, maybe there are my colleagues who not agree with me. The best option is the radio surgery because it's safe and with very good result. I have more or less 20 patients with metastasis. 7 of them are intramedullary, and the result is very, very important. And in the last slide is that the radio surgery is an essential part of the paradigm of treatment of intracranial tumor, but also the spine lesion. And we are just studying. We have not so big experience, but I think that step by step we can gather enough experience to make the good decision. And as my friend invited you, you are everybody invited in the 25th Congress of World Federation of Neurosurgery that Dr. Lafuente and Dr. Luis Ley are organizing in Madrid. Thank you very much.
I take your idea on the separation surgery. I'm very keen on separation surgery, but only on the most demon cases. I mean, when there's compression in the spinal cord, I tend to remove the pressure in the spinal cord, and then second stage maybe fix the spine, and then you can do radio surgery. Certainly not for benign tumors, which I intend to take them out. Certainly not for tumors metastasis like the one you showed, which was outside the spinal cord. I think it's always better to take them out in the safest way possible.
because you have to get into the spinal cord. The patient will be in severe disability, but it's outside, and then CC2 will be certain guarantees. So the surgery is good for metastatic disease, as you say, for many cases, yes, but not for all cases. And of course, when you are dealing with a big metastasis in the bone, that will weaken the bone, and certainly that will destroy the bone inside, and it will cause a collapse of the bone. So for those cases, also radiosurgery plus instrumentation is another alternative. And this has been a good response.
Thank you
very much. Nice talk.
Yes, I agree with you, absolutely.
Excellent talk. What do you think, which tumors, apart from that, do you think spinal radiosurgery is the first one?
Well, I think that this is a very interesting question. I think that in some kind, it's very difficult to understand. I think that in benign tumor, we can try to make surgery. It's been the only benign tumor where to try and make surgery. But for example, if the tumor that I have, the neurinoma of the D1, and where D1, D2 is very difficult, we have to make transthoracic approach, and we do it. I do it, but we cannot take out all the tumor. I think with the benign tumor, I will try everything to make surgery before. And if we have recurrency, we have to make radiosurgery. This is my answer.
Was an excellent presentation. Sometimes it's hard to combine the radiotherapist radiosurgery and insulin without going. The patient has many. They say we need to know that this is a metastatic technology. So how do you deal with that? Because biopsy of the organism. The second one, you have spoke about ADMs. Which is the experience with the are ADMs? Because it's very complex.
Well, the first, to answer the first question, I think that is very important that the strategy of the treatment of a spine tumor has to be, the decision has to be the first one from neurosurgeon, and therefore from radiation oncologist. And the strategy has to be dirigido, I don't remember it in English, from the neurosurgeon. It's very, very important in the unite of radiosurgery, the neurosurgeon to be present and to make the decision, because there is a very important pathology. This is my first answer. The second, I was thinking to put it about the ADMs, you know, that we are in the center, the only center that treat intramedullary ADMs. I've treated until 95. There are only few publications in the world about the ADM. We can speak about the classification of the ADMs. In the ADM classification, only the second group, that is glomus type ADM of the medulla, we can make radiosurgery. My results are excellent. And in the 5 patients with intramedullary ADMs, all the ADMs have been disappeared. Well, the last one was a combine of the ADM with the venous cyst, and is not closed until now. But I think that the intramedullary ADMs, if I think that the first option is radiosurgery, the type 2 intramedullary ADM that are glomus ADM, they have to make radiosurgery, not to make surgery or not to make embolization, because the results are so good.
It was big advantage to us because I have similar problems in my hospital, and I had one case similar to yours. It did very well with brain metastasis, brain had a spinal one, and the Microsurgery coach gave all the options and this, you kept the patient and tell him that 3 biopsy you have a high chance of tetraplegia, bleeding, and blah blah blah. On the other hand, we have seen how the patient have responded to radiosurgery in the brain. Therefore, we can give blind radiosurgery to the spinal cord. Now, there's not an issue, and if we say so, provided the response in the brain has been satisfactory. If not, then I would not wish, particularly if it's asymptomatic, to do radiosurgery on the spine.
Some guys are coming now with the cover nose malformation, which is the result are surgery sometimes. If you have any echo or something.
One case. I have one case. This is a big discussion that I have with my friends, with Luis, with Kiko Comparesiano, with that, what to do with cavernoma. We have a big discussion about how to treat. How to treat. Well, I think that we can make surgery in the cavernoma if there is a neurological deficit. We can do it. If it is accessible in point of view of the surgery, yes, near the posterior part of the medulla, but in the case that is not very accessible of surgery, I'll make radius surgery. I make only one case surgery. The cavernoma was bleeding. The patient with hemiparesia, the palsy of the left side, and I was waiting when the hemorrhage disappeared a little bit. I can see, I wait 2 months that I can see very good where is localized the cavernoma. I make radius surgery. The cavernoma did not disappear. This is the big problem, that the cavernoma does not disappear after the radius surgery. There is no it. But the patient, the hemorrhage disappeared. The patient have not more hemorrhage. And with physiotherapy rehabilitation, he became the same situation before the bleeding. This is one case. I think personally, but we have a big discussion with this friend of mine, that the cavernoma that make hemorrhage, that have bleeding, and there is a deep localization, we have to make radius surgery. Absolutely, this is my opinion.
Thank you.
Yeah, we know it, we know.
The cavernoma, of course, is a benign lesion. And if the cavernoma is not bothering the patient, we don't bother the cavernoma. Not even with first statement. Then, if the cavernoma has left, of course, there is a role for radius surgery. Might be, I say, because if the approach is too dangerous to the patient, you seldom see that situation, but sometimes it's very dangerous for the patient. The radius surgery might have a role, but in my experience, almost, especially in cavernomas, again, bothering the patient. Other cavernomas that left before. You have an approach, I would say, 90-something. 90-something percent of the time you can approach. So surgery is still the first option and might be, but the surgery for these cases might be an option. As it's been in brainstem carcinoma, the same.
Yeah, but do you remember this case we discussed together a very thin carcinoma? I make posterior approach with.
We would agree that the brainstem is different because it's bigger.
Yeah.
It's more difficult to find a case without an approach in the spinal cord.
Okay. Right. I'll try. Let me see in the future. I know it, mentor. I know this is not the problem. Don't open the door. Thank you very much.
Maybe in the future,
I can demonstrate you step by step.
Every tumor may be sorted by medicine.
Yeah.
Maybe.
So, Dr. Elmira Paya, she will talk about neurohypophysitis.
Perfecto.
Thank you for the presentation. I'm an early stage neurosurgeon in this newborn hospital that professor presented before. When this meeting was planned a couple of years ago, I was still a resident in the Mother Teresa department. I'm glad to be here with you today, and I'm going very briefly to present, considering that's the time, two case reports about inflammatory lesions of the mandibulo-hypothalamic region, two cases that have been evidenced to have inflammatory lesions in the hypophyseal area and have been then treated in our center in the last 3 years. These are the only two evidence cases in these 3 years. In general, hypophysitis is a general concept that puts under the same umbrella several inflammatory conditions of the hypophysis and can be caused by local or also systemic inflammatory conditions. In these terms, a multidisciplinary follow-up, diagnosis, and treatment of the patient is very important. And the role of neurosurgery in this context is limited into absolute indications. Only when the edema is not, the local compression is not resolved by high doses of corticosteroids, and when the diagnosis is necessary. Unfortunately, the non-invasive diagnosis remains elusive, even though the development of new techniques for immunotary diagnosis and biochemistry has been developed recently. In the first case was a 29-year-old woman who started with first symptoms after her first pregnancy, and after a couple of years of complaining of polyuria and dyspepsia that was then referred to diabetes insipidus, headache, hypogonadism, and a severe uncontrolled weight gain, was referred from the endocrinologist to our clinic. In the MRI, we noticed a hypothalamic lesion and that several differential diagnosis between a glioma, graminoma, and lymphocytic hypophysitis was on cards. The CT brains, in the CT brain, we noticed the presence of edema and a lesion near to the hypophyseal region, whereas the contrast MRI showed inflammatory conditions, particularly in the infundibular and neurohypophyseal side. This is the coronary section of MRI. It was possible to do open biopsy to this patient, and the material was sent to our collaborators in London, Dr. Latifai. The report showed that the diagnosis of lymphocytic infundibular neurohypophysitis, one of the most common forms of hypophysitis, confirmed by a GFAP background, who confirmed the presence of the hypothalamic tissue, so we were in the right side. No proliferation, local proliferation, and presence of CD20 and CD3 lymphocytes that favored the lymphocytic infundibular hypophysitis diagnosis. The follow-up was obviously then integrative. The patient was sent back to the endocrinology, and she continued the treatment with substitutive hormones, levotiroxine, desmopressin, and hydrocortisone, according to her laboratory findings. Unfortunately, she had severe recurrent crisis with two recoveries in the intensive care unit because of the hydroelectric balance impairment and severe sessions of confusion and memory loss. At the last 2 years of the first diagnosis, the patient underwent exitus letalis, probably also because of the difficulties in the compliance and follow-up in the integrative care. The second case is a 41-year-old male who was referred also after several consultations from endocrinologists and andrologists for diabetes insipidus and erectile dysfunctions. The MRI showed a very similar condition with hypothalamic infundibular lesion, and we followed the same protocol. You can also see here the lesion. They are very similar, showing a contrast enhancement in more or less the same area. And the Material was shown then from a cocktail of the antibodies tested that were in favor of the diagnosis of Langerhans self-histiocytosis. So in this case, we have again the inflammation of the region, but coming out from systemic inflammation. However, from the endocrinology point of view, both of these diagnoses are put on the same track to follow up. In this case, the main follow-up was sent from the hematologist. The patient underwent chemotherapy, 6 first cycles with vinblastine, which is our protocol. And then after 2 years, he had a recurrence, and cytarabine has been also tried with a very good result, as referred to his hematologist that we contacted not more than 2 weeks ago. At present, he continues the hormonal treatment with testosterone, derogenroxine, and desmopressin, and insulin according to his needs, without need for hydrocortisone. The clinical situation is, however, in a difficult equilibrium in terms of the quality of life. He's a father of 2, so he's still part of his family. He still has a Clover-Bruce syndrome, so characterized by problems in behavior and difficulties in memory. In conclusion, we can both these cases show that inflammatory lesions of the hypothalamic infundibular region are rare, but biopsy is often a must for the diagnosis, and the multidisciplinary follow-up is needed. Pertinent diagnosis, pertinent patient compliance, and the strict integrated follow-up are determinant factors for diagnosis. Thank you very much for your attention.
Is among the 5 women neurosurgeons that we have in our society. We opened to the women 10 years before. Congratulations. I just want to comment the case. I have a very strange case out of hypothesis. A large carcinoma. 3 years later, came with a similar patient, and we were a bit surprised because it was a complete removal. We do a follow-up after 6 months, and there was no adenoma there. And 3 years later, we do follow them for 5 years. In 5 years, they have no more adenomas, and we stop follow-up. We take them non-symptomatic. So in that about 3 years, you had a very similar large lesion, going more backwards. So we went in, we wanted to take the tumor out. It was too strong, too hard to take out. We take it out completely by an endoscopic approach. We send the microbiology, we send the pathological examiners, and it came back as a hypocytosis. We handed over to the endocrinologist, and eventually, a year later, it was performed. We are writing this paper for 600 pounds.
Interesting. They are reported in the literature, but I think Professor Capella has also a couple of cases that also, when were referred back then, last case with an abscess of the hypophysis.
Yeah.
That's very probably, or it's another case. Thank you.
We have seen some few cases. In case we suspect usually very quickly wait because sometimes it prevents. The treatment surgery here is easier with both the very risky. You wait and see. You said, sorry, you said the first patient died 2 years after the diagnosis. But how long after the surgery?
2 years. It was 2 years also, because the diagnosis coincided with our surgery. Actually, the symptoms were very early. She had also a problem of compliance, I would guess, in the treatment and following up of the. It's challenging, actually. It really needs a lot of work from family too, from medics too. And thank you.
So Dr. Adrian Roch is going to talk about cases of neuroenteric cysts.
Thank you very much. I'd like to present 4 cases of neuroenteric cyst. Short briefing. They are very rare, occurred especially in the spine cord, but also intracranially. According to the World Health Organization, represent 0.01% of all intracranial lesions. The pathogenesis is unknown, but the hypothesis is related to the failure of obliteration to the neuroenteric canal during the 4th to 3rd week of gestation of embryogenesis. This failure results in an incomplete separation of the nodal cord with displacement of endodermal cells. There are a lot of synonyms like enterogenous, endodermal, enteric, bronchogenic, etc. Per definition, they are non-neoplastic cysts with well-differentiated epithelium, localized more in the spine, but the 75% of the intracranial lesions are localized in the posterior fossa, 95% axial, and the supratentorial have a frontal perforation, or most common site. Have a peak of in the 3rd decade of life, and especially in the women. They are very rare. In the literature, I reported not more than 80 cases. The radiological findings are very different because due to the component or the well-differentiated cell, they appears in different intensity. The best diagnostic tool are magnetic resonance with contrast, flare, and diffusion. Pathogenesis macroscopically or gross pathogenesis is different: transparent, thin walls, smooth, round, or lobulated. The content of the cyst depends from clear to viscous, dense, and mucoid. Histopathology are very large difference because of the differentiated cells. Differential diagnosis: epidermoid cyst, dermoid cyst, cystic schwannoma. There are malignant transformations reported 8 cases in the literature, most common adenocarcinomas. The first case is an incidental finding in a 52-year-old woman. The MRI shows a pontomedullary junction lesion. No sign of compression or neurological deficit. So the MRI after 1 year, no change in the radiological image. So, but the patient disappears from the follow-ups after 1 year. The second case is a young adult, 36 years old now, diagnosed at the first time in 2015 with pontomedullary lesion. This is the first MRI in 2015. In 2021, he presents sign of oculomotor nerve compression, of the left oculomotor nerve compression, and surgery was suggested. To the left retrosigmoid approach, there is evidence the keys to white with component gelatinose, aspirable. I'm sorry. Sorry. The histopathological report is an cyst lesion with fibrous wall lined by ciliated epithelium, neuroenteric cyst, and the MRI show total resection and preserve all the nerves. Third case is a 40-year-old woman present with 5 months of headache and sign of increased percranial lesion. The initial radiological diagnosis, it's similar to hemangioblastoma with a mural cyst with a mural nodule. The patient underwent surgery to the midline suboccipital craniotomy, and the blush lesion was immediately visible. The case have hemorrhagic, old hemorrhagic liquid, and the dissection initially laterally and inferiorly. Smooth like dissection. Calculation of the capsula and the aberration. This is a typical case because generally they are localized anterior to the frontomedullary junction. And the total resection was acute. This pathological report show what cystic lesion lined by pseudostratified ciliated epithelium surrounded by neuronal tissue, and all macrophage with hemosiderin. The diagnosis was a neuroenteric cyst, and the MRI showed total resection of the lesion. The fourth case, very interesting, is a 37-year-old male underwent surgery in 2002 for a skull-based lesion. The pathology, as at the time reported by Professor Gian Gasparo, was an neuroenteric cyst. He disappears from the follow-ups and came in 2019 with posterior fossa infra and supratentorial lesion or recurrency. The patient underwent surgery through an old pterygoid craniotomy with the brown cystic wall and the component, the dissection from the third nerve, coagulation of the cystic wall. The brown liquid came out. Opening the ambient system on the other compartment of the posterior fossa lesion, and to the end, MRI shows an almost total resection of the lesion. The pathology response was cyst wall is lined with mono to multi-layer non-ciliated squamous epithelium. Keratin flakes are seen, and was an neuroenteric cyst with an appearance similar to the epidermoid cyst. To conclude, total resection is possible, provide the best long-term outcomes. Incomplete excision may lead to multiple surgery, including cystic drainage and recurrency, and rarely malignant transformation. But long-term conservative treatment and regular follow-ups are the best choice for patients with no neurological deficit. Thank you very much.
Very nice presentation.
Thank you.
So Dr. Ramos Brace will talk about surgery of temporal lobe epilepsy. Okay.
Perfecto.
Good afternoon, all. So, we're going to talk about the selective transcortical hippocampectomy in Albania. Epilepsy is a very common condition, affects nearly 1% of the world population, has very long-term and debilitating symptoms. Most patients, about 2/3 of them, achieve good seizure control with anti-epileptic drugs, but about 1/3 are resistant to therapy. In drug-resistant epilepsy, surgery has been well established as a very superior treatment in a few randomized controlled studies. Anterior temporal lobe procedure, which has been modified by Spencer, has been the mainstay procedure in our department and has been achieving good seizure control. The first step in surgical evaluation of the patient is the clinical and semiological seizure characteristics, which at our department are evaluated by a senior epileptologist. Also, the ictal EEG recordings and the prolonged video telemetry help better find the focus of the seizure. 3 Tesla MRIs are very helpful in localizing visible lesion, also evaluated by a senior neuroradiologist, and the neurocognitive evaluation is done by the neuropsychologist. There are several approaches in temporal lobe epilepsy: the standard temporal lobectomy and the one modified by Spencer. Also, the transcortical selective hippocampectomy developed by Neymar in 1958. In our experience, we had 50 patients over 10 years, and 35 of them were hippocampal sclerosis, 12 focal dysplasia, and 13 were lesional. Out of these 50 cases, 12 were selective hippocampectomy, which were either focal dysplasia or lesional, and the rest were treated using the ATL as modified by Spencer. As I said, it was first described by Neymar in Brazil in 1958, before the advent of MRI imaging and neuronavigation. This approach uses the transcortical T2 transventricular route to reason find the
Excuse me, Doc, you're muted. Excuse me, we have no sound. We have no sound. Please unmute. Can anybody hear me? Ahmad, can you hear me?
Yes, Professor, no sound.
Yeah, no sound. Okay, let me get back to them. Let's see, that maybe, let's see how many more webinars we have here.
They started no sound and finished no sound.
Oh, okay. Okay. Let's try. We'll work on it. Please unmute, please. Arthur, you need to unmute, please. Oh, man. Hola, está terminada. Está terminada.